Who's missing? We have an almost. Probably good exercise carrying all that mess around from one office to another.
We'll finish.
When he came in, he had 2 bags and an umbrella. And
I don't understand.
you know all about it.
I understand. I had one. They finally gave you one that worked.
This meeting of the Mississippi State State Board of Medical Licensure to order. And Dr. Ann Ray, and from Columbus, the President of the Board, Michelle Owens, the Secretary, Dr. David McClendon is Vice President, and we're going to begin with an invocation and a pledge.
Stand. Lord, we come to you just thankful for your gift of life and the blessings that you give us. We have new leaders in our country that we pray for your wisdom and blessings and the decisions that they make. Lord, we pray for the health of our state. We pray for wisdom in the deliberations that we make and the difficult decisions that we make. Lord, we pray for your guidance in everything that we do. We ask for forgiveness of our sins, and thank you for everything you do for us, Lord. In Jesus' name we pray. Amen.
We have a new administration, but we have the same flag. So let's pledge. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Make a couple of introductions. To my right is Ms. Alexis Morris from the Attorney General's office, who helps us with our administrative proceedings here. And our court reporter today is Ms. Julie Brown. Glad to know.
No, okay. Tammy Folger. Tammy Folger.
Tammy Fulgham. Oh,
Miss Francis and
I got the wrong speaking note, didn't I? Ms. Fulgham, we're glad you're here. Okay. All right. I have no announcements to make for the public, and usually this time we invite some public comments. Seeing none, we'll proceed with the executive director report.
Thank you, Madam President. Today's report should be rather brief. In licensure for the months November and December, we issued 125 new licenses. That's on par with our monthly average. One podiatrist. Through the compact, we issued state and principal licensure for 37 licensees and licensure qualifications for 9. No new PA license were issued, and we issued 372 certifications to other states. In investigations in November and December, we received 111 new complaints. We closed 117 cases, which gives us 124 open cases. Just to give you a baseline, of last board meeting when I reported that number was 180. Cases closed within 7 days, 47%. We requested 307 PMPs and 113 of them required additional action. I like to throw in a little bit of interesting data. I don't know how interesting this actually is, but we have now successfully transferred our old legacy data from the history of the board into the new system, which was a really big step for us. And y'all should never see or know any difference really, but internally we know and see a difference. And we're currently working with DaltSpan to begin the data sharing with the Board of Nursing and the Pharmacy Board, who also use the DaltSpan platform for their licensing and investigations. So it should be very cohesive amongst the medical board, the licensing, the Board of Nursing, and the Pharmacy Board. So we're excited about that as well. And with that, if anybody has any questions, I'll be glad to answer them.
Dr. Edley.
Dr. Cleveland, isn't it normally in January when we license the new graduates from the PA school? So January or February, they take their exam in December, I think, and graduate, then they get one.
So I'm not familiar with exactly what their graduation schedule is, but I was under the impression that they come along the same time our new licensees from medical schools come along.
No, they normally, because when we're looking for job hires, it's normally January, we're waiting for them to get their full license.
Okay.
But the code do things off, but it does something.
And maybe so, but I mean, as you saw, we had no new PA license issued. And if what you're saying, and I have no reason to not believe that it's correct, then we probably will see a big jump in the January, February numbers that I'll report on March. So.
Any other questions? Thank you.
All right.
Okay. Need approval of the minutes of the executive committee meeting dated November 18, 2020. Give you a moment to look at those minutes over.
I make a motion to approve the minutes.
Second the motion.
Okay, Dr. Lippercott, second.
Second.
From Dr. Miles. Any discussion? All in favor?
Aye.
Any opposed? Okay, we'll approve those minutes. Approval of minutes of the board meeting dated November 18 and 19 of 2020.
Move to approve.
Dr. Owens, second.
Second.
Dr. Miles, all in favor?
Aye.
It
Oh,
was
that was
McClendon.
Dr. McClendon, okay, sorry.
Charge the report.
All in favor?
Aye.
Aye.
Any opposed? Okay, those are approved. Report of January 20, 2021 Executive Committee meeting. Dr. Owens.
So the executive committee did convene on yesterday. There were 2 personal appearances, and the activity of the executive committee was as follows. With respect to the personal appearance by Dr. Iyad Hashan, his request for waiver was denied by the executive committee. And regarding Dr. Lampros Papadimitriou, his request for a waiver was granted.
Okay, thank you. Reports from committees. Dr. Owens.
So the scope of practice committee has not had any items to come, but do we need to?
Yeah, we
We
need
need
to,
to-
we need to, for the full board to vote on the executive committee actions. We need a vote of approval from
Oh.
the full board.
That's true. Okay. Motion?
I make a motion, we approve.
Okay. All in favor?
Aye.
Any opposed? Okay, thank you. Appreciate that, Dr. Cleary. Okay, let's go back to committee, scope of practice.
We didn't have any items to come up before the scope of practice committee. And so there, we have not convened, have no items.
Okay, professional sales program, Dr. Hickenthal.
No report.
Okay. Telemedicine interstate licensure compact, Dr. McClendon.
No report.
Licensees education and communication, Dr. Owens.
We have no official report, but as you all know, we've started the communications that are going out through the publishing of the newsletter, and our next newsletter should be forthcoming, I think, in next month. It'll be next month. So keep your eyes and ears peeled for that.
Okay. Physician Assistant Advisory Task Force, Dr. McClendon.
So we have a yearly meeting with the physician assistant leadership in the state. We had that meeting yesterday for our executive committee meeting. Nothing really significant from an agenda or policy standpoint. We were updated with the status of the schools. There's now a new physician assistant school at Mississippi State at the Meridian campus. The Mississippi College program is a robust, active program. And it was just a good meeting just to hear the latest of what's happening in the physician assistant world. And so, but nothing else to report.
Okay, thank you. Rules, regulations, and legislation, Dr. Lyons.
We have some things here going on. This is not anything we're gonna have to really approve. This was approved last time. And this is for you to look over it to make sure that there are no errors, things you don't want to put down. This will be filed with OLRC. And this is your last chance to look at it before they go. And all of this has to do with nurse practitioner, the definitions, types of clinics, mileage, definitions, and it's all stuff we talked about last time.
Okay.
So just to remind everybody, if I may, and after the board approves it, it has to be on the website for a period of time for people to be able to make comment on it before the board final approves, and then at that point it goes to OLRC. So that's where we are today.
All right.
This is mainly, we changed some things to make them more legible and readable, and really with very little content, if that makes sense.
Have any discussion? Everybody had a chance to look over these documents. We do need to approve this day to go on, okay? I need a motion.
I can't make one.
So are we gonna do these one by one, or are we doing them together?
I would recommend taking them as a group, since the board has already approved them and passed them in previously.
Yes, as a group.
Okay, just one.
So move accept the entire group.
Okay. Dr. Edney and Dr. Riefenstahl, all in favor? Any
Question.
opposed?
If we send these to the committee, and let's say 3 of them, and I approve them sent back, do we just go back and work on those 3 then? Or
Right. That's-
I'm expecting something to be sent
Yeah.
back, I don't know what.
We're approving all of them as a group for expediency's sake in this meeting, but each one will go separately to the, they have you split everything out, and they look at each one separately,
They
so,
will all be done individually with the OLRC.
and so if they throw out 1 or 2 and send them back, we'll deal with those, and only those.
I'm not enough of an optimist to think they're all gonna go through like that.
Wow, Marza. another day, as I say, so.
Dr. Gersh, for your vote too, would you mind just raising your hand? It might be a little easier for us to see than it may be to hear.
Didn't
there.
realize he was
Yeah,
there.
he's there.
Where is
He's
Back
there.
in that,
corner.
up in
Gersh is
that
there.
corner, in that little bitty box.
Looks like he lost weight, Dr. Gersh. I can't see him.
He's small.
Okay, I'm glad you pointed that out. Okay. Hospice ad hoc committee, Dr. Edney.
Thank you, Madam President. We completed our work, as you know, and the board voted last meeting to accept the recommendations and endorse those recommendations from the committee. I've communicated that fact to the interested parties. There's still some confusion, as you can imagine. One thing that might help is perhaps if we just have Dr. Cleveland work with rules and regs to finalize whatever we need to do legally to satisfy those at the Capitol that we have indeed done what we were asked to do. But the ad hoc committee's completed our work.
Okay, well, thank you for all that. You've done a good job. And so, where do we need to go from here? We've already approved the recommendations to the ad hoc committee. And what do we need, a form to send to the legislature?
Well, I think the decision last time was to work on a declaratory statement, and we've been passing that around a little bit. We just haven't completed it yet. So we just need a little bit more time. Maybe
Okay.
at the next meeting, we'll be able to present a
Alright.
declaratory statement on hospice.
Okay, great. Thank you. Okay. Begin with approval of consent order for Arthur Philip Fine. It's number 9 in your tabs.
Was this is just
Okay.
a mirror action, correct?
Any comment, Dr. Cleveland?
You want Sorry.
Okay. And this is just a, Dr. Cleveland, this is just a mirroring action of another state, or?
Yes.
Okay.
Consent order on Dr. Klein.
Yes.
This is a consent order being presented to the board. Dr. Klein has already executed the consent order. It's being submitted to the board for its approval. In essence, it mirrors the actions of the state of West Virginia, wherein they reprimanded Dr. Fine for a number of different violations. And I'll read a very brief summary of what basis for actions in West Virginia. Say Dr. Fine prescribed hydrocodone benzodiazepines to 2 separate individuals without appropriate documentation of the doctor-patient relationship or other documentation required under the West Virginia Medical Practice Act. The hospital reported that they had met with Dr. Fine to discuss his concerns. Dr. Fine acknowledged that there was no documentation of an ongoing treatment plan or his prescribing to these 2 individuals, one of which was his wife. Basically prescribing controlled substances without maintaining proper records and to document the doctor-patient relationship. West Virginia reprimanded, and this consent order mirrors that reprimand.
Okay. Need a motion to accept the consent order?
So moved, Owens.
Second.
Second, Dr. Miles, all in favor?
Aye.
Any opposed? Matter of approval of consent order on Scott Taggart Rothel. Rothel? How do you say that?
Rothel, but I'm not sure. Very similar. This is a consent order which Dr. Rothel, Scott Taggart Rothel signed. It's mirroring actions taken by the state of Iowa, which really mirrored actions by the state of Alabama, but it really does. And what this does is mirror those actions as well. In this case, Dr. Roselli was charged and stating that all about December 20, 2019, the Iowa Board entered into a stipulation finding that Dr. Roselli failed to conform to the minimal standard of acceptable prevailing practice in medicine when he prescribed medication to a patient via telemedicine without establishing an appropriate physician-patient relationship sufficient to establish an informed diagnosis
and provide appropriate care. Controlled substances were not involved, but there was a combination of different various topical medications which he prescribed. The board alleged that Dr. Robille failed to perform an adequate interview of the patient, to collect the relevant medical history, and or perform the physical examination sufficient for a diagnosis and treatment. That action was taken by Alabama as well as Illinois. It was an official reprimand, and this consent order mirrors those actions as well.
Okay. Any questions?
If we mirror this, are we gonna find $5,000 too?
It's not in our practice act to be able to find.
I know.
Yeah.
Well, we know. Very nice.
Okay. Need a motion to accept the consent order
So moved.
Second.
from Dr. Owens. All in favor? Any opposed? Okay. Pursuant to Mississippi Code 73-2461, a matter of review and discussion be held in executive session due to material being exempt from the Public Narrative Act.
Make a motion,
To close the meeting?
Close this meeting.
close the meeting to consider whether to enter into executive session on this matter.
Second.
All in favor?
Aye.
Okay, we'll enter executive session.
No.
Francis needs a couple of seconds to come from the ladies' room.
By all means.
And you got your COVID vaccine?
You
So we're
watch
not-
that movie,
I'm supposed to get my second
what
one.
about
Well, let me tell you something.
Protected, right?
Yeah, we're not announcing.
I just want to know.
Yeah, yeah.
You know what you can,
about
no, they got it.
Okay, you can just say request granted or whatever. the
We
case
weren't
is.
gonna say
They
anything.
wanted
We were just gonna.
So every 2 bottles, the next drug.
was it about Hugh Long or the other Long, one of the governors
Down
Long
around the plant line.
in Louisiana and, Miss Star, Bella Star. And, he's taking this woman to a deli with him. Somewhere in Baton Rouge, I think it is, and she looks like ladies in the table. Of course, that's the time you wouldn't ask me anything like that. You tell me what the ladies were. One looked at the other and said, just ask me, the ladies. I wonder what she needs the ladies. You know what? Exactly. We're on it. We're on executive session, coming back into regular session. I'm going to have Dr. Owens read the conclusion.
The board decided to deny has decided to deny the request for early termination of the contract.
Do you have any questions?
If I were to, how exactly does this work? If I were to practice in Texas and,
Okay,
Texas
since
does not
we're in-
require-
Since we're in the public, we're not going to get into your situation. We'll tell you that this is a final decision from the board right now to deny your request for early termination of that contract. You will receive a letter informing you of that.
Let me address your issue. I think your question is,
No, Dr. Pham, Dr. Hamilton and I can be in touch with you about those issues.
Okay,
that's good.
Yeah. Just to clarify.
Okay, thank you.
thank you.
Let's see, where
Well,
is my agenda?
well, it's in the very beginning.
Right here. All right. Our next item on our agenda is to show the cause hearing in the case of Yusuke Yahaji, MD, Victoria, Texas.
Dr. Yahaji has withdrawn his application, reserving the right at a later time that he can get, reserving the right at a later time to resubmit his application once he gets some of the issues out of South Dakota resolved.
Okay, thank you. Number 13, hearing in the case of Frank C. Wade, Jr., MD of McGee, Mississippi.
Pursuant to a request, timely request for a continuance, opposing counsel made the request. I have no objection to a continuance.
And we'll grant a continuance. This is the first one, right?
Yes.
Okay.
We know, opposing counsel knows to be available for a hearing in March.
Okay. Item number 14, hearing in the case of Sean X. Wu, MD of Gulfport, Mississippi.
Dr. Wu's attorney has also made a request for continuance. They also have that set for the hearing in March.
Stacking up March, aren't we? Hearing in the case of Jean Marie Barker, MD, Woodville, Mississippi.
Dr. Barker is here with his proceed.
Others just get up in the morning and decide they continue.
have Dr. Gene Barker before us.
Yes, this is
Ingram.
this is a matter in case of the board versus Dr. Jean Marie Barker. This is Dr. Barker. Representing Dr. Barker is Kenny Lawson. We're ready to proceed.
Okay.
Is it okay if I sit down or trying to keep my mask so you can hear me?
I'm going to defer to Ms. Morris for these proceedings.
Good morning. I'm Alexis Morris. I'll be the hearing officer in this matter. Before we begin, I just want to, for the record, point out that we do have a quorum present. And if we could just briefly introduce ourselves, starting with the executive director at the end, Dr. Cleveland.
Dr. Ken Cleveland, Executive Director.
Dr. Dan Diddy from Vicksburg.
I'm Dr. Ken Lippincott, who's below.
Dr. Charles Miles from West Point.
David McClendon from Ocean Springs and Vice President of the Board.
I'm going to point out that Dr. Gersh from Hattiesburg is on Zoom with us. And I'm Dr. Ann Ray of Columbus, and I'm president of the board.
I'm Dr. Michelle Owens from Jackson, Mississippi, and I'm secretary of the board.
Kirk Kennard from Oxford, Mississippi.
Eric Herrick from Richland, and a consumer representative.
Wesley Breeden from Hattiesburg, consumer.
I see you all have exhibits. Are you ready for those to be placed into evidence, or would you like to wait?
Usually, let's go ahead and place those into the record, and I believe opposing counsel wishes to make a statement before we proceed.
Okay, you may.
Thank you so much.
We have already,
Go ahead.
we have already pre-marked all the exhibits. Do you want to make your statement now, or we'll wait till we?
And just one little thing on the, there was one exhibit I reviewed that was the complaint that was filed with the board by the patient one's family, was that I didn't know, is she going to be called to testify, or is that just to go into the record?
That's all. Okay. You may proceed when ready.
All the exhibits have been marked. They also have a handout. I'm handing out is an exhibit list, shows the number and a brief description of those exhibits. And also, the other exhibit identifies who the patients are and makes reference to the patient number. You will know that the summons and affidavit filed in this matter does not reference any of the patients by name. We're not concerned with who the patients are. We're concerned with the care that was rendered. So throughout the hearing, you'll hear reference to patients 1, 2, and 3. We'll have documents that you look at, but we have not redacted the names, but you'll note with this list, I ask that you keep in confidence that identifies patient's name, so that when you're looking at some of these exhibits in executive session, you'll know which patient number we're talking about. And doctor, when you testify, if you would have the same list in front of you, so when I refer to patient 1, 2, and 3, you'll know what I'm talking about. Okay. Exhibit number 1 is the summons and affidavit filed in this matter just to establish pleadings. Exhibit number 2 is an excerpt from the medical license of Dr. Jean M. Barker, MD, showing that she was issued a license before this board in May of 1990. That's board exhibit number 2. Board exhibit number 3 is a transmittal letter from Dr. Barker with a copy of the consent order, which this board, some of you may recall, considered and declined to accept. And the reason I put that in there is because this consent order gave the board then the right to review some of the facts and circumstances prior to that decision. That's board exhibit number 3. Board Exhibit number 4 is the complaint which prompted the investigation. The complainant is not being called as a witness, but this is for your information. Board Exhibit number 4. As to patient number 1, I have several exhibits, and I'll summarize the facts momentarily. Exhibit number 5 is the medical record for patient number 1. Exhibit number 6 are the original prescriptions issued by Dr. Barker to patient number 1, along with the printout from the Mississippi Prescription Monitoring Program. That's exhibit number 6. Exhibit number 7 is the death certificate for patient number 1, along with the results of the pre-hospital care report from the ambulance and the report of death investigation. This is board exhibit number 7. Board exhibit number 8 is the expert review of that particular file by Dr. Raul Vora from New South Neurospine. That's board exhibit number 8. As to patient number 2, the medical record for patient number 2 is board exhibit number 9. The original prescriptions and prescription monitoring program printout as to that patient is board exhibit number 10, and the expert review of that record and report from Dr. Raul Vora from New South Neurospine as to patient number 2 is board exhibit number 11. Board exhibit number 12 will be the medical record for patient number 3. Board exhibit number 13 is the original prescriptions and the prescription monitoring printout for patient number 3 pertaining to the prescriptions which Dr. Barker issued to that patient. And board exhibit number 14 is the report from Dr. Vora as to patient number 3. In that regard, I will point out one of the witnesses which I plan to call is Dr. Andrew Watson. Dr. Vora was required to be in Atlanta today to testify in a federal DEA case. And so Dr. Watson has conducted his own individual review of the documentation and the reports from Dr. Vora, and will address that during his testimony. Exhibit number 15 is an affidavit from Stephanie Mueller, Director of the Mississippi Prescription Monitoring Program. Board exhibit number 16 is a curriculum vitae for Dr. John Andrew Watson, expert. And the last exhibit is number 17. Although this board takes judicial notice of its rules and regulations, this case is a little bit different because the time periods in which Dr. Barker treated patients 1, 2, and 3 preceded, and in some cases was after, the board adopted substantial changes to the rules and regulations governing the prescribing of controlled substances for chronic pain. As you know, those rules were substantially changed effective October 20, 2018. So just for the record, I've attached the rules and regulations of the board effective October 20, 2018, and the rules and regulations of the board prior to October 20, 2018, which is in effect the rules and regulations that were in effect from 2013 to 2018. And that would be board exhibit number 17, and represents all of the exhibits which you will have when you go into executive session and we will use during the testimony.
Any objection, Ms. Lawson?
No objection.
So admitted.
Did you have any?
Have any exhibits?
I beg your pardon?
Are you using our exhibits? Is that primarily?
Yes, I had planned on that. Is that all
Okay.
right?
Yes, that's fine.
Good.
At this time, if we can swear in any witnesses before we begin,
Our two witnesses, be Dr. Watson and Dr. Barker.
would you all stand and be sworn in at this time? Yes.
Do you swear or affirm that the testimony you are about to give is the truth, the whole truth, and nothing but the truth, so help you God?
You may begin.
You have an open.
Just if it's all right, just a quick opening statement. Good morning, I'm Jenny Lawson. I'm with the law firm of Barner, Parker and Sessoms in Vicksburg. I recognize a lot of the names on the board. My primary practice is medical defense work. I work for the good guys, that's what I always say. Just an opening, I'm asking that this board keep in mind, one of the things I found striking about reviewing this case and working with Dr. Barker is the community in which she works. It is unlike a good portion of the state. It is the Delta. There are lack of services available to those folks that don't have money. I'd just like to keep that open to the board also, as Mr. Ingram has stated for the record, the majority of the treatment that's going to be presented to you was prior to that 2018 change in the rules and regulations. So please also keep your mind open to that. Some of these things were before that was implemented. I'd also like to just add that Dr. Barker has been in the Delta for 30 plus years. She has her own family practitioner clinic there. And during these times, there were generally no other family practitioners available. So I'd just like ask the board to keep all that in mind. Thank you.
I'll proceed with the brief opening statement.
Yes.
I believe the summons and affidavit has been attached to the board's agenda, so, and presumably all the board members have read the charges. Allow me to summarize. May I sit down?
Yes.
I can put my reading back. What you have here is a summons affidavit setting forth 8 different counts as to patients 1, 2, and 3. Patient 1 is count 1, 2, and 3. Patient 2 is counts 4, 5, and 6. And patient 3 is counts 7 and 8. Count 1, 4, and 7 charges Dr. Barker with prescribing controlled substances outside the course of legitimate professional practice. Count 5 charges Dr. Barker with failure to comply with rules and regulations that were in effect both prior and after October 2018, which requires that an informed consent agreement be entered into between the licensee and the patient, which clearly dictates to the patient you see only one physician, you only use one pharmacy. In other words, setting out the parameters, what we call the pain management contract, which this board is certainly familiar with. As to patients 1 and 2, that contract is nowhere in those realms. Counts 3, 6, and 8 is unprofessional conduct likely to deceive, defraud, or harm the public. What the evidence will show is that Dr. Barker prescribed outside the course of legitimate professional practice, and as a result, obviously placed the patients at risk of potential harm, thus unprofessional conduct likely to harm. Now, all 3 patients received substantial quantities of controlled substances from Dr. Barker at a time when Dr. Barker knew or should have recognized clear, unquestionable indications of potential abuse and drug-seeking behavior, yet failed to promptly address the issue in a manner which fell below the standard of care. Patient number 1 died of an overdose. Partial. That's one of the reasons, three separate reasons cited in the death certificate. One of those was polysubstance overdose. We are not trying to prove, because I don't think the evidence is sufficient to show that she directly caused that overdose, because the patient was also getting medication off the street. But at the time of the death, the time the ambulance got to the home of this particular patient who died, an empty bottle of methadone was found at her side as issued from Dr. Barker. Empty bottle of methadone. Patient number, in all fairness to Dr. Barker, she did terminate patient numbers 2 and 3. And as you'll see, the evidence is clear and unequivocal that well before she terminated these patients, each one was exhibiting behavior indicative of drug abuse, drug-seeking behavior. And the whole point of being charged in each of those cases is that she did not address those issues soon enough. While patients 2 and 3 were ultimately terminated, as I said, that termination was not soon enough. In all 3 cases, Dr. Barker managed these patients below the standard of care. Very little or no diagnostic tests were acquired to support the multiple complaints of pain and to rule out malingering behavior, which I think is unequivocally clear. Basically, she let, in many cases, the patients dictate the management and care. No effort to treat the underlying cause of pain. In essence, by prescribing all these controlled substances, she was treating the symptom of pain only. Most importantly, Dr. Barker failed to address early on the above obvious indications of abuse. We're talking about positive urine drug screens for medications she did not prescribe, or negative urine drug screens for the medications that she did prescribe, which put her on notice that something was wrong. Multiple complaints, especially in cancer patient number 2, multiple complaints of pain from every part of that patient's body. Backache, toothache, abdominal pain, ear pain, headache, eye pain, joint pain, pelvis pain, thumb pain, hurting all over, neck pain, facial pain. When a patient comes to a doctor with all those sources of pain, and that's in addition to the back pain, which is the primary source of the complaint, that put Dr. Barker on notice of, you got a problem. You'll see evidence of concomitant prescribing of opioids, benzodiazepines, and buprenorphine. The concomitant prescribing of opioids with buprenorphine is questionable. Black box warnings are clear. Do so with very much caution. As I said, there's no pain contracts for patients 1 and 2. And I think evidence can show through the expert testimony and testimony of Dr. Barker that she did fail to respond quick enough to the obvious signs of abuse, and her management of these patients fell below the standard of care. Anybody else to say?
Yes, I apologize. I misunderstood step 4. That was my opening statement. Okay. But I would like to point out a couple of things based on his opening statements. Again, as I said before, please keep an open mind to the community that Dr. Barker is serving in regards to these particular patients. You're going to find all 3 of these patients that, while I know as a medical physician, you should not discount or give more credibility to somebody who comes from a poor socioeconomic background. But at some point in time as treating physicians, we have to have some compassion for people that are dealing with long-term struggles. And that can be anything from, what's perceived pain versus real pain. Pain is subjective and not objective. There are things you can do. And I believe that Dr. Barker will testify as to each 3 of these patients. She stands by the treatment she rendered these patients. I think some of the allegations in there are that she didn't document enough. And in my practice, I have always said we don't treat patients, we don't treat charts, we treat patients. And what one doctor may see is insufficient. Another doctor may say, well, I can understand the totality of the circumstances. I would also like to point out that I believe early on, and that's part of the amended affidavit as far as the history, my understanding was at some point in time in February 2020, there was a consent order presented to Dr. Barker. She executed that fully and returned it to the board, agreeing to operate under a set of circumstances or rules under the close monitoring of the board. And she continued to operate under that consent order until July, when she was notified that actually had never been actually signed by the board or accepted by the board. And I also would put before the board today, she has been in her community 30 years. She is well dependent on position in that community, and she is willing to do and operate under that consent order if the board should so decide to go ahead and enter into that. She did operate under that for the first 6 or 7 months of 2020. That's all. Thank you.
I would call it, this Dr. Barker, call her as an adverse witness.
Does she need this, or she has a microphone?
Yes.
Okay.
Good morning. For the record, would you please state your name?
Marie Barker,
I see you brought several things with you to assist your testimony. Can you identify what those documents are briefly so the board knows what you're looking at?
Dan, can we move her closer to the microphone, please?
amended affidavit.
Ms. Barker, excuse me, you can remove your mask if you,
Amended affidavit.
You can remove your mask if you wish.
thank you.
Amended affidavit. Answered affidavit. New South Neurospine.
Patient, which patient?
Yeah, it's all that.
This is, I guess, the witness is. This is the board room. This is. And this has patient information.
And if I could, just for the record, what is in that notebook is everything you produced to me after page 1, 2, and 3.
Fair enough. Thank you. You've been licensed since 1990, is that correct?
In Mississippi, yes.
Please use the microphone.
Okay. In Mississippi, I've been licensed since 1990. Before that, I was licensed in Minnesota.
Your specialty is family medicine?
Mhm.
You've been practicing family medicine in Mississippi since 1990?
Yes,
Any board certification?
I have family practice board certification.
Okay, you maintain that board certification?
I have.
Have you received any particular training for pain management?
Not specifically pain management, but I did go through the Suboxone program in 2017 and to address the opiate problem in Greenville.
So you're currently authorized to treat how many patients with Suboxone?
100.
Now, did that, you presented and the board declined to accept the consent order back in 2019?
It was the beginning of 2020.
2020. And you heard your counsel's statement that since then you pretty much tried to comply with that consent order, even though it wasn't accepted by the board.
Yes.
Have you changed your approach by not prescribing opioids as much and turning those to
Oh, yeah.
Suboxone?
I mean, yes. I mean, many of these people have pain and addiction. And anyone, I think, that's been on opiates for prolonged periods of time has an addiction problem in addition to their pain problem. And when I got the consent order, I did not write any more pain medicine, and I either switched the patients to Suboxone if they wished to be switched to Suboxone, or I attempted to refer them to pain clinic. At the pretty much exact same time the COVID thing happened. And none of the clinics would accept people, or at least not many of them. And we have a clinic currently in Greenville run by Dr. Oakes. He did not take any of these patients.
Is that paid clinic?
Yeah. Greenwood took a few people, only a few people. Some of them went to Jackson, a few of them went to Vicksburg. But most people did not find a pain clinic that would accept them because they were not taking new patients because of COVID.
Am I reading between the lines? Those are the ones you put on Suboxone.
Not really. I mean, I spoke with each patient about whether they, felt that they wanted to do that. And I'd say maybe a third of them switched to Suboxone.
Have you utilized the entirety of your 100 allocation of Suboxone patients?
I know.
How many Suboxone patients do you currently have?
I don't know exactly. I believe it's around 50.
50. Let's talk about patient number one.
Okay.
Into the board, you would agree this is a 31-year-old female that you initially saw on December 4, 2014. Is that correct?
Yes.
The chief's complaint was hip pain and bipolar disorder.
Well, no, not. She didn't mention bipolar disorder at the beginning.
Doctor, turn to that. Let's go ahead and turn to that patient chart. If you turn to let's go ahead and get the patient chart out. Turn to your initial office visit, December 4, 2014. I can present you what's been placed into evidence. I got that marked. If you read.
Okay. Yes.
Read the chief's complaint.
Hip pain and bipolar disorder.
Thank you.
Okay, I'm sorry.
That's all right.
I didn't. But it became clear to me as I saw the patient more that she probably did not have bipolar disorder. And the reason I say that is because she never exhibited mania. She just exhibited depression. I know for a fact that her grandmother was bipolar, but I do not believe that the patient was bipolar.
With that in mind, turn to the very last entry, very last office visit that you have. I believe it would be the August 15, 2016, immediately preceding her death on August 20. You'll see, read the chief complaint.
Bipolar disorder.
If you turn the page, you show the impression, bipolar disorder, and partial remission. Most recently, depression. Is that what?
Yeah, I mean, depression was how she presented almost all. Not mania. And I really do not really believe. I believe she came with that diagnosis from somewhere else, and I really believe that she was not bipolar. I believe she was depressed.
I'm jumping the gun here. Show me anywhere in the documentation where she was referred to a psychiatric evaluation to address.
It's
The
not
bipolar disorder
possible,
or
it
the
is
depression.
not possible. At the time, we had one psychiatrist in Greenville. His name was Dr. Jenkins. He did not accept Medicaid. There was no option to send her to psychiatry.
So your testimony for this board is there was absolutely no option available for this patient to be seen by a psychiatrist, whether in Greenville or any other city or local area.
Well, you know, I don't know if any other city, but nothing within our area. There was only all we had was the mental health center, which had doctors on and off
Did you refer him to that?
at times.
Did you receive any documentation from the rural health center that you considered as a part of this patient's record?
No, she wasn't going there.
Okay. With that understanding, from December, you're not, that's the fact that from December 4, 2014 to August 15, 2016, 20 months, you issued 20 prescriptions for 1,522 methadone 10 milligrams, 13 prescriptions for 785 Lyrica 300 milligrams, 62 Lyrica 150 milligrams, and 60 Lyrica 75 milligrams. You don't deny that?
No.
While you acknowledge that while the social history states no illicit drug use, and on your initial visit, no reference to drug problems. Later on, she acknowledged crystal meth past and crack cocaine use recent.
Okay, yeah, the patient had some drug screens that were positive for cocaine and crystal meth. She lived with a man who was a known methamphetamine addict and had been in prison twice.
You're treating the methadone that's being prescribed for the purpose of pain.
Yes, she
Well,
had.
let me finish my question.
Okay,
And that was for hip pain, is that correct?
basically, yes.
Section 2640 rules 1.7C1 states that before initiating treatment with substance or other drug having addiction involving or addiction sustaining liability, licensee must, doesn't say may, must conduct a risk-benefit analysis by reviewing records of prior treatment.
Yes, and I believe we had her record of prior treatment. She had been seeing Dr. Beecham.
Where are those records?
They were not in her chart at the time because of the fact that her chart had been put out in the shed. And when they did that, they thinned the chart and they took some stuff out. But I knew she was taking methadone from Dr. Beecham at the pain clinic, and so I would have had to have had some records at one time. Because it says there I didn't query the TMP on her at all, so I had to, that was the only way I knew she was taking that from Dr. Beecham.
What diagnostic test did you run to determine etiology of the pain, the hip pain?
I believe that it was done over there.
Doctor, that's not in the record.
I'm saying that when we sent the records, we did not have it in there. And I believe that later on, I realized that I had seen this patient when she was young, when she was a teenager, or maybe even slightly before she was a teenager. And I remembered at that time that the patient had had congenital hip dysplasia,
Which side?
both sides.
One moment you're diagnosing it, saying it's a left hip. The initial visit, you said it's hip pain as a result of a motor vehicle accident.
That is what it said in her, that's what it said in Beecham's record.
One moment you said right hip pain, the next moment you said left hip pain, and then later on you said congenital defect. Which one's correct?
I believe that she had bilateral congenital hip dysplasia. I remember, but I have no access to those records because the EMR that I was using at the time is no longer active.
So you should, am I to understand that these records exist, but you had no, for purposes here, you had no ability to obtain them?
I cannot obtain them now because although we had a cross-reference for that chart, we had them in boxes in our shed. They were cross-referenced to the patient. We have the cross-reference paper. We do not have that box or her chart. And what had happened was that a shredder came to shred stuff, and they were supposed to shred certain things. But it turned out they probably shredded that in mistake. But I do have the electronic, the electronic record, which did not include these other things.
So you're asking the board to consider a diagnosis of the underlying, determine the etiology of the pain based on records which you don't have and we can't present to the board.
Yes.
You stated here that other than reference to injections by Dr. Beauchamp, there was no documentation of any non-pharmacological trial. So you did not send her to any other specialist to address the hip pain.
No, I did not.
Make reference to a Dr. Beauchamp. Who is Dr. Beauchamp?
Dr. Beauchamp was an anesthesiologist who ran a comprehensive pain clinic in the Delta until approximately 2016.
Are you sure you're not referring to Dr. Beecham?
Beecham, yeah.
The record says Beauchamp. There's no such
Okay,
doctor.
what I'm saying, okay, Beecham, it's spelled Beauchamp, but he pronounced it Beecham.
Doctor, I spoke with Dr. Beecham. His name is not spelled Beauchamp. Beacham.
Okay, all right then.
Uh,
I don't know. I don't know why that got in there like that. I'm not sure. But it's the same person that I'm referring to that ran the pain clinic, whatever his name, however his name is spelled.
Again, none of his records are in your file.
I know that.
Doctor, you ran 3 urine drug screens on this patient.
Yes.
You realize that no drug screens will run until during the first 16 months of your treatment of this patient?
This was before they were required to be done and before I had them in my office.
Doctor, don't you think it's important?
I think it's important, but it was not until it came out to get drug screens that I looked into getting them at my office. And at some point in 2016, I got them in my office. And then we started doing monthly drug screens.
There's a reference on April 15, 2016,
Yeah.
which is well before the board required it for every visit. You ran a drug screen that says negative for amphetamine. That's good. But the result of the drug test are not in the record. What about the methadone that you were prescribing in the literature?
Lyrica does not show up.
All right, what about the methadone?
Methadone only shows up on certain drugs.
You're the one that controls the drug.
Yes, I had drug screens at that time that did methadone. And if I did not mention it, since I do not have the chart, but I sent everything that I had on the chart to the board in 2018. And some of it seems to have disappeared somewhere in the board because that stuff was in there when we sent it. And I referred to, we had an extra paper in the chart that was the drug screen. And it screened for multiple things, 12 different things, as opposed to what the hospital screens for, which is 6.
I'm talking about your drug screens. You make reference, for instance, on April 15,
All right,
2016.
because I didn't mention methadone, perhaps it was in there. Most likely it was in there.
Don't you think it's important to note that in the record?
I put in the record what was abnormal. In my electronic medical record.
All right, let's look at the June 16, 2016. Again, this is well before the board report. It was positive for methadone and cocaine, and you wrote in the record, her boyfriend says she used it, referring to the cocaine.
The boyfriend was the one probably who gave it to her.
Did you believe?
I'm guessing.
Did you believe that when you wrote the boyfriend said she used it?
Yeah.
You believe the boyfriend?
Yes, I do.
Thank you. At that time, you discontinued the methadone. Basically, you're saying, you got a positive urine screen for cocaine. I'm not going to write you a prescription for methadone. Is that correct?
Yeah.
This was on June 16, 2016. Is that correct?
Probably.
You also wrote in there, when you said patient and her boyfriend were quite upset. You're referring to the fact that you said, I'm not giving.
They were both positive for that.
Okay, so the boyfriend was also a patient.
Yeah.
So they're both positive for cocaine. So you said, I'm not going to write you a prescription for methadone. Then you wrote, patient and her boyfriend were quite upset. What does that tell you?
What do you mean?
Well, if the patient was very upset, and her boyfriend for that matter, since he's also a patient, if they were upset because you said, I'm not going to write you a prescription for methadone, what does that mean? What does that tell you?
It tells you they were addicted to it.
Thank you.
And everyone who has been on narcotics for any period of time is going to be addicted to it. Not because that was their preferred drug, it was their preferred addiction drug.
Drug of choice.
What? They did stimulants, and especially he did stimulants, not her. But sometimes she did it with him, was the situation.
All right, so in June, you said, I'm not going to write you a prescription for methadone.
Yeah.
They came back a month later, on July 15, 2016, and you ran one screen. Is that correct?
Yeah.
It's positive for methadone. After you had cut them off.
Well, that's not to say they didn't have some left over.
But that didn't seem to concern you at all? They could have gotten it on the streets, I guess. Is that what you're saying?
I mean, I don't know whether they got it on the street or not.
I don't see any documentation of a confrontation with this patient. Well, wait a minute. I cut you off from the methadone and now you're positive. Where'd you get it? I don't see any confrontation documented in the record. Why?
Because the records are maybe not documented quite as well as they ought to be. But I had talks with all of these patients every time they came.
Why don't you turn to that July 15, 2016 entry? I've just got a few more questions about patient number one, then we'll move on. July 15, 2016. Okay, so you had previously cut them off from the methadone because of the positive cocaine urine drug screen. She comes back on July 15, she's positive for methadone. But what's her complaint then?
She was having pain.
No. Chief complaint, read that for me, please. Hip pain and
Drug problem.
drug problem. So she recognized she had a drug problem, is that correct?
With cocaine.
She also put in there, she does need methadone for her hip. She has promised never to do cocaine again. Is that correct?
Yes.
Then you stayed under the plan. You're in drug screen, positive for methadone. I did give her methadone, 10 milligrams twice a day. I will call her in the drug testing next week. I don't see that in the file. Why didn't you insist on she coming in for drug testing?
You don't have my drug test.
Doctor, when they subpoenaed these records, we wanted everything. Where are the drug tests?
I sent the drug tests. I do not know why they are not in there anymore. I sent them here. And I also checked before I sent any of these things to the board that they all had drug agreements in the chart, and they're not in there either. I don't know why. I can't say.
Let's turn to the last date
Yes.
that you saw this patient alive. Okay? August 15, 2016. You agree with me, the chief, following the chief complaint of right hip pain, previously was left, of right hip pain and bipolar disorder. You state, patient presents today with the complaint above, which is right hip pain and bipolar disorder. She is here for refills for medicine. She really wants more methadone. She's in lots of pain. She needs more Nexium. She'd previously come to you, doctor, stating the previous month drug abuse, drug problem. And you had previously treated this patient for methadone 3 times a day. Then you cut her back to 2 times a day. Here's a patient stating she's got a problem. Why did you increase her medication on that day to 3 a day?
Because that was what she was taking before. It was not a new dose. And I told her if she behaved herself with the cocaine, that I would consider rape.
In retrospect, you think that was a good idea?
I think it had absolutely nothing to do with her death.
Why, doctor?
Because the patient told the ambulance people that she did not take the methadone.
You previously testified.
She said it was stolen the day before. And when she came to the hospital, she did not die of methadone overdose. She died of shock and sepsis.
Okay. The death certificate says respiratory failure.
Yes.
Prescribing of an opioid.
She did not have respiratory failure initially. She spoke to the ambulance people and she told them she did not take the methadone.
I hear what you're saying. Respiratory failure, sepsis, renal failure, multiple drug overdose.
The multiple drugs that I was referring to were cocaine and methamphetamine. That was what was in her urine when she was in the hospital. I have accessed the chart. That's what was in her urine.
Moments ago, you testified that when the boyfriend stated that she had taken cocaine. You believe it, correct?
Yeah.
Let me read the narrative from the ambulance. Patient should climb in bed, patient alert but very lethargic and confused, noticeable cyanosis around the lips, patient pale and cool, initial blood pressure 45/22. Skip a little bit here. Boyfriend presents empty bottle of methadone that was filled yesterday. He states he thinks she may have taken them. Patient denied and states that they were stolen.
Yeah.
So you don't believe the boyfriend now?
You can believe people about certain things and not other things. If they admit to taking cocaine, I'm pretty sure you can believe that. But if she had an empty bottle, I mean, it's entirely possible, I suppose, that he stole them. Because he had a bigger drug problem than she did and has been in prison twice for that. And it was stimulant problem.
All right. All this information and background. You find it concerning that there's no patient contract, pain management contract anywhere in this?
I believe the patient had a pain management contract at some time. And I believe that we sent it to the board. That's what I believe, because when the board requested those charts, I checked to see if everything was, you know, ducks in a row and all that. And I did not, they all had pain management contracts, every person that I gave him.
You understand initially when the board obtained this record, there was questions as to they wanted to make sure they got everything. So we made a second request and subpoenaed those records. That would have been a great time to make sure that everything was in it. Why didn't you do
They
that?
did not make a second, they did not
Yes, ma'am.
subpoena my records a second time.
Yes, ma'am. They got it. You're very cooperative. Your staff provided that record.
What do you mean? Like, they told me they didn't send any.
All right.
But at the time, but if you said in 2020, we did not have a paper chart. Because we looked for it. We went out to the shed and we looked for it under the cross-reference system, and that box was not in the shed.
What you're saying, you can't produce a record you don't have?
Yes. That's what I'm saying. But I had the paper charts in 2018. I did not have the paper charts in 2020. In between, I assume they got shredded at the time they were shredding things, but
Doctor,
it should not have been shredded, but it was.
Bottom line is, Doctor, the pain management agreement is not in the record. You acknowledge that.
It's not in what you have.
That's fine. Is your testimony before this board is patient number one that you prescribed all controlled substances clearly within the course of legitimate professional practice?
Yeah.
So you don't see, and you state you had a pain management agreement, you just don't have it.
I do not know what happened to it, and I do not trust the investigator that came. Put it that way.
You're saying this board's gonna change records to make sure that you can't defend yourself? Is that what you're saying?
I'm saying that I don't trust Mickey Bowie. That's all I'm saying.
You
Because I've
acknowledge,
dealt with him before, and I didn't trust him then either, and I'm just not, you know.
you acknowledge the fact that
Because when he first
Doctor,
came,
let
he
me-
didn't even subpoena, he did not even subpoena the records. He gave me a written list.
Doctor, you understand that if this board finds that you prescribed outside the course of legitimate professional practice, prescribing controlled substances under those circumstances could potentially harm the patient. You agree with that?
No. I mean, I don't think that harmed the patient.
So you don't think you've done anything wrong with patient number one?
Not really.
Okay, let's talk about patient number two.
Got patient number 2. Let's see.
In terms of your initial, you would acknowledge in this case, this is a 35-year-old female that you initially saw back in 2013, on July 15, 2013. Is that correct?
Yes.
You treated this patient for a period of 4 years, 47 months to be exact, from July 15, 2013, excuse me, July 25, 2013 through June 20, 2017. I think it was on June 20, 2017, about the time you terminated the patient. Is that correct?
Yeah.
Make sure I go over the prescriptions. During this 4-year period, you issued 12 prescriptions for 660 Norco 7.5, 30 prescriptions for approximately 2,090 Norco 10 milligrams, 1 prescription for 30 methadone, 1 prescription for 60 Suboxone. You don't deny those prescriptions.
No.
2,840 doses. You realize that? Agree with that?
That's what we found up to.
At the outset, you look at the very first day, July 25, 2013, what was the chief of complaint?
Sinus problems and back pain.
You're looking at July 25, 2013?
Wait a minute, no.
Yeah,
It's at the end, I guess, right?
Yeah, you're referring to, I'm using the records that you've given me, and it says the span is from June 11th of 2015 through 12/04/15.
I'm looking at the initial visit of July 25, 2013. I know that,
Is it, we'll go with the first of the page. This is printed out from what you had sent me on the CD. And it has this on here, and that's where it starts. You're gonna have to give a copy of this because we don't have any of those pages.
you would acknowledge that this is your record.
Yeah.
Okay, make sure we're on the same page.
And what was that date again?
That was 7/25/2013.
Thank you.
chief complaint was toothache and a rash, is that correct? Doctor, would you agree with me that a patient comes to you and almost every visit there's another complaint of pain from various different sources? That could be a red flag that she's drug seeking. Would it surprise you that this patient, when you look at the records, complained of the following sources of pain: toothache, abdominal pain, ear pain, headache, eye pain, joint pain, pelvis pain, thumb pain, hurting all over, close, neck pain, facial pain, in addition to pain.
When she had the neck pain and the facial pain, she'd been beat up.
2 times that she complained of being assaulted and attacked, creating pain. Does it surprise you that this patient, when you look at the prescription monitoring program, saw 15 different prescribers, 10 different pharmacies, and 11 different addresses? Actually, 5 different addresses, excuse me.
It doesn't surprise me that, because toward the end, PMP'd her and I found that out, yeah. But I may not have seen all of them because some of them were 2013 and I don't think that I was told them at the time.
With that page, turn over to an entry on December 30, 2013. Sorry, December 4, 2013. Yes. I actually have a tab for you, Doctor. Okay. He states she wants narcotics. Complaint, not on the right side, abdominal pain. The patient presents today with a complaint above, which is not on the right side, and abdominal pain. She feels like she has a knot on the right side. She also has pain in her upper right quadrant. She wants narcotics. Flip over to the next page under the plan. What does it read? Plan, the next page.
On what? On which date?
That's the same date, So you have 2 pages for that date. The plan states, I ordered her a CT scan of her abdomen with contrast. I do not really think anything is going on there. She insisted on Lorcet for her chronic pain. Doctor, who makes the decision as to whether or not you prescribe narcotics? You or the patient? You think you've complied with that?
In retrospect, perhaps not.
I'm sorry.
I said in retrospect, perhaps.
Rule 2640, Rule 1.7C1, which is in effect at the time you treat this patient, provides that you must conduct a risk-benefit analysis in favor of treatment with controlled substances for chronic pain. The results of the analysis must clearly be entered in the record and must include supporting documentation such as consultation or referral report or an effort to trauma to determine the underlying cause, etiology of the chronic pain.
Well, the patient definitely had scoliosis. It was evident on examination.
And is scoliosis painful?
Sometimes not.
You state on December 30, 2013, I explained to her scoliosis was not necessarily painful. The patient states she absolutely needs narcotics. Then on September 4, 2015, you state that the lower back pain is probably from scoliosis. Is that correct? Where is the definitive diagnosis? Where did you refer this patient for a more comprehensive workup?
What's a more comprehensive workup on scoliosis?
I'm asking you.
Scoliosis is a condition that occurs during teenage years. And it's not really treatable after that unless you're having compromise of respirations or something.
All right. Look at December 30, 2013. December 30. It should be tabbed there for your convenience.
Okay.
Then you, on the second page, under planning, you state, I explained to her scoliosis was not necessarily painful. She says that she absolutely needs narcotics. I explained to her that Lorcet will be changed to Norco. I gave her Zipromax, Z-Pack for sinuses and flexural for back pain. I referred her to Dr. Beecham.
Yeah.
That's the Beecham you
Yeah.
talked about earlier. Show me where you referred to Dr. Beecham and got the results.
I didn't. At the time, well, anyway, I don't know what was happening during that time, but he may not have accepted. I mean, I don't know because he was, doing different things in different years.
You're surmising now because there's nothing in the record. Would you agree with that?
Yeah.
So after taking in excess of 22,700 Norco over a period of 4 years, on June 9, 2017, this patient presented to you with a complaint of opioid withdrawal. Can you turn to that page, please? June 9, 2017.
Yeah.
The chief complaint is back pain and anxiety. The patient presents today with the complaint above, which is neck pain and anxiety. She is here for refills of her medicine. She is rather upset that her daughter is not getting a lot of pain medicine. She still says that she is anxious about the assault from last summer. You were also prescribing pain medication to your daughter?
Well, I only prescribed pain medicine when she got beat up.
She's rather upset that her daughter is not getting a lot of pain medicine. Her daughter was beat up, is that what you're saying?
Yeah, they were both beat up. I believe that the patient was a prostitute.
Okay.
And she was beat up by people fairly regularly.
June 9, patient complained of narcotic withdrawal. Patient presents, complaint above, narcotic withdrawal. She wants off narcotics. She wants to start Suboxone. So at that point, you agreed to try Suboxone with this patient, correct?
Yes.
but you had to receive prior authorization. So you gave her a prescription for a small amount of methadone to cover until she can get the prescription.
Yes, and now, in the retrospect, that was a stupid thing to do.
Okay, tell me why.
Because of what happened later.
Are you referring to the fact that?
She filled both of them.
You mean-
And then she said she flushed the methadone, which was probably a lie.
And you terminated her.
Yeah.
Your treatment of patient number 2 preceded the board's adoption of the rules and regulations of the board, which required that when you're treating pain management and you're prescribing a controlled substance for chronic pain, that you need to run a urine drug screen and do a prescription monitoring profile query. Is that correct?
Yeah. But some were run.
That's my point. You you asked for a PNP as early as bear with me. The exhibit. Present you with board exhibit number 15.
And I would also point out that those PMPs we sent here too, when we sent it, and they're not in there either. That's why I think some things are missing.
You're blaming that on Mickey Boyd too?
Possible. I mean, he's the one who brought it. I mean, I don't know. I can't say what happened to them. I was not there. I don't know exactly what they did with them. But I know they were in there when we sent them.
All right. Okay, you've got a prescription. You ordered one, actually 2 queries with the PMP on September 19, 2016. Here's your PMP for particular patient number 2. I'll give you plenty of time to look at that, but would you agree that on September 19, 2016, you ran the query as you say you did, and as the PMP said you did, you would have discovered this patient was also getting Norfolk from Dr. John Berry, lorazepam from Dr. John Jenkins, dextroamphetamine and prazolam from Dr. Monica Hodges, that may be a nurse practitioner, I don't know.
Yeah.
Acetaminophen with codeine from Felicia Preston, acetaminophen with codeine from Deborah Baxter, APRN, and lorazepam from Dr. Chester Jenkins. Doctor, you were put on notice of this doctor shopping, if you will, and also put on notice of the myriad of various complaints. Do you not agree with me that this patient should have been terminated early?
In retrospect, it's possible. Now, she was going to other doctors at that time. She stopped going to most of the other doctors when I told her that she needed to do that. When I first found out she was going to other people, and I said, you can either come here or you can go to those other doctors.
You would agree with me that knowing that she's getting all these medications from the doctors, she's what we call the competent use of opioid stimulants and benzodiazepines. That's a pretty dangerous combination, would you agree?
Yeah.
find it concerning that now that you ran, that you did not run a query with the BOD until almost 3 years and 2 months into a 4-year period?
Well, the PMP was only accessible at some times back then. And it's because when we signed up, the people were not, my staff was not able, my staff changed and my staff was not able to sign up for the PMP. At least that's what they told me. So anything I ran back there had to be done by me personally, and I had lost the password to it. I'm just telling you, you know, I mean, that, you know, and I did not really have access to the PMP at all during all this time.
You got this report from the director of the PMP, Stephanie, you in front of you. I was curious, you terminated this patient, I think it was June 20, 2017. Who is Gwendolyn Ann Wilkes?
That was my front desk person.
If you terminated her in June of 2017, why did you run a PMP profile on her in July 5 in 2018, a year later? You're still treating her?
No, that was when he asked for the question. That's when he asked for the record.
Oh, so when the medical board staff asked for the records in 2018, you ordered a profile just to see what you had prescribed to this patient.
Yeah.
Okay. Let's talk about patient number 3.
Mr. Ingram.
I've just been informed that lunch has arrived. Do you think that we could take a brief lunch break and then
This
you
would be a
could?
good time to break, but or I could go ahead and do patient 3 and then take it.
How, it,
I
how
would be
long
on, I
is,
think I can get it done in 30 minutes.
let's do
Patient
3.
number
What do you think?
Do
they wanna take a vote?
Likely story, huh?
No,
Whatever y'all want to do, we can do it now. Is the food back there?
Yeah.
Well, that's fine.
Okay, let's go ahead and take our vote.
How long are we gonna come back?
When are we gonna
When do you wanna
reconvene?
be
You know how long it's been, 30 minutes.
What's good for them too.
What do you wanna do?
We haven't had a.
12. Do you wanna do 12?
Okay.
We can come, we can break and come back at 12:30. That's fine.
Sorry.
All right, break at 12:30.
Okay, that's fine.
Perfect.
Okay, we're in recess.
Yes.
Arlene, can you hear me? Arlene?
Under the crime section, coming out the bottom.
That would
Yeah,
still be
why would you
easier
do that?
than having to. No payday.
We look for the low.
Did you get you some lunch?
No, I didn't hear you. Try it again. Can you hear me? Yeah, I can hear you. All right, come.
I don't know. I have to have some sort of devotion to sleep.
You let them know we're ready to get started now.
Hear ye, hear ye.
Okay, if we can get everybody in place. We're a minute later than anticipated. Do you like that congressman that slobbered all over his hands and hacked and coughed and then put his mask back on?
Yeah.
We are.
Okay, is Dr. Barker and Ms. Lawson, are they back? I haven't seen them.
Oh. Okay. Well, then that means I can go look at them.
Yes, sir.
Well, might make dinner. That'll surprise some people, including me. Yeah. Not before I get back. 3 minutes. 2 pieces. Go in 3 minutes.
Ms. Lawson, we had to tease Mr. Ingram, and he and a couple of other attorneys we see up here that when they give me, they say, oh, this won't take but a couple of minutes, and an hour and 40 minutes later.
That never happens. That never happens.
If you say you smoke half a pack, we know it's half number one.
This is just
General rule.
Let me get a cup of coffee.
Look, that's off the record since we haven't started the hearing.
The longest we've ever stayed is 2:45 the next morning. And that was just gonna be a few minutes. And the last one was a video deposition. I slept through that. I couldn't.
I'm glad we're off the record.
Yeah.
Can't be saying that on the record.
11 hours. I mean. Video.
I can tell you, I am free. I am not one of those that have to pound every back into the record. I'm sitting in front of a bunch of educated people that have been here and done that. Yeah, it is. Or in my case, I'm a part-time municipal court judge over at Vicksburg Municipal Court. And that's really easy.
In the meantime, did you all want to do those?
Yes, we do. We need to do that before we get back into the hearing. Do we know where Dr. Barker is?
Yes, they got turned around. She said they were somewhere around the Slotsky's and coming back this way.
Okay.
I mean,
Well, I got a little bit of business to take care of before she gets back, and I think we'll just go ahead and do that. We're back from recess. We're back into the meeting. We had mentioned some consent orders that we got reports on, and each one of them needs to be approved individually. So let's begin with the, okay. And the consent order of,
It was just the continuances.
continuances. Okay, continuance for Dr. Wade. I need a motion and a second to grant the continuance.
So moved.
Second
Okay.
one.
All in favor?
Aye.
Any opposed?
And then 14 is Dr. Wu.
And Dr. Sean Wu, order of continuance. I need a motion to accept?
Move the way accept.
A second?
Second.
All in favor?
Aye.
Any opposed? Okay,
That's it.
that's it. We just had the two continuances.
About the next meeting.
Next meeting.
It's the last item on the agenda.
Okay. We'll get it up here, don't worry.
I wonder why.
We usually meet the third Wednesday and Thursday. However, I have some conflicts, and I would like to move that to March 24th and 25th, if that's okay.
Well, yeah, because the 17th and 18th of spring break, is during spring break.
For those of you who still worry about spring break, it is spring break, so.
Your executive director is one of those.
But I'm all for it because I'm relieving somebody who is taking care of spring break, so, okay. Is everybody okay with 24th and 25th? All right. Very good. Okay, let me put that in.
Have we had any word about the meeting? It's usually in April. Are we doing a virtual?
Okay, that's the Federation. That's the next item.
Oh, we got that too?
That's the next item of, it's the next to last item on the agenda. And who's got the details on that? Dr. Cleveland?
So I was just trying to read it real quick. On behind tab 16, you have a note from Dr. Chaudhry. It is just essentially saying that the FSMB 2021 annual meeting will be virtual. It does give you the dates, and they're April 29th through May 1st.
And it's still got some CME.
I'm sure there will be potential CME that you can get there. Everything will be the same. It'll just be virtual.
Okay, and the House of Delegates is my responsibility. Dr. McClendon, are you gonna be my backup on that in case I get called out or something? Okay, so we got the House of Delegates taken care of. Well, one thing about being virtual, at least you don't have to worry about when your flight plans were and go, oh no.
That's right. It's much easier on Francis.
Okay, so that's those items. And, all right, Dr. Barker is back in place. Dr. Barker, we were just taking care of a few items that are no concern with your hearing in the meantime. So we're going to proceed with your hearing, and you're still on the stand for Mr. Ingram.
Thank you. All right, doctor, let's turn to patient number 3, if you would. Let me provide you that medical record. Use the benefit of the tab. I'm referring to board exhibit number 12. All right, you would agree with me, this is a 33-year-old female. This is that she presented on the initial visit of October 24, 2016. Of the 33-year-old female initially seen back in 2006 with a diagnosis of depression, chronic anxiety, and postpartum cardiomyopathy. 2007, she saw there's an entry that says she thinks she might be bipolar. During an eight-year gap, did she return to you in October 24, 2006? Does that sound about right?
Yes.
Okay. Turn to the October 24, 2016 entry. You have that? You have.
Yes.
You would agree with me that the chief complaint was chronic pain with Crohn's disease. Is that correct?
Yes.
Okay. Read that entry if you would. Oh, I can read them, make a difference.
The patient presents today with complaint about which is chronic pain with Crohn's disease. I have not seen her for 8 years. She has developed Crohn's disease about 4 years ago. She had her gallbladder removed and was supposed to have her terminal ileum removed, which was affected by Crohn's disease. They did not remove it. She has chronic abdominal pain. She is constipated. All of her joints hurt, including particularly her hand joint. This is related to Crohn's disease. She also has arthritis. She is depressed and sees Dr. Jenkins for this. Dr. Takari told her that she needed a regular doctor for her medicine. She got very sick from Humira. Currently, she is only on Humira.
All right, thank you. You treated this patient beginning in October 24, 2016, until June 19, 2019, when you terminated the patient.
Yeah.
And during this period of time, I don't think you don't dispute the number of prescriptions and dosage units prescribed. Over a period of 30 to 2.5 years, you issued to this patient 86 prescriptions. That's 31 prescriptions for 2,220 Norco, 31 prescriptions for approximately 2,790 buprenorphine, 8 prescriptions for approximately 390 prazolam, 15 prescriptions for, that first one was prazolam 1 milligram, 15 prescriptions for approximately 420 prazolam 0.5 milligrams, and 1 prescription for 75 clorazepam 1 milligram. You don't dispute that. Yeah. You realize that's 5,895 dosage units over a period of 2.5 years. In your answer, you stated that you did not diagnose patient 3 with polyarthralgia. Is that correct?
Arthritis.
Or polyarthritis, as she never had joint pain, only abdominal pain. That's out of your answer you found on this board.
Well, evidently she had some joint pain, but she said she was taking her medicine for the stomach.
If she had joint pain, you disputed the complaint filed in this matter against you, which stated that there's no evidence that you ever referred this patient for a workup by a rheumatologist. And why?
Not a rheumatologist. She was attending the gastroenterologist because Crohn's disease is gastrointestinal problem.
She also complained, as you wrote in your first chief complaint, all of her joints hurt, including particularly her hand joints. She complained about joint pain throughout. Why did you not ever refer her for a rheumatology workup?
Because Crohn's disease is in most cases taken care of by the gastroenterologist.
All right.
And she had one of them.
You dispute the fact that almost virtually for every visit you entered a M6.4 diagnosis of inflammatory polyarthropathy.
Well, that's what the patient told me. But when she spoke to me, she generally talked about her stomach.
Doctor,
That's why she said she was taking her medicine.
You rendered almost virtually every visit that diagnosis of inflammatory polyarthropathy, and you never referred her for a rheumatoid workup. Is that correct?
That's correct.
Now, so it's your position that the primary basis for that over 5,000 dosage units of controlled substances was because of pain due to Crohn's disease.
Not all of it. You said.
I'm saying it's your position, because you denied a minute ago that she was taking the pain medication for her joint. You said
She was not taking it for her joint. She was taking it for her abdominal discomfort with Crohn's disease. And the gastroenterologist had put her on that.
Which gastroenterologist?
At one point, she saw Dr. Tucker, at one point, she saw a doctor in Jackson, I believe his name was Dr. West.
Dr. Thackeray was the local dentist,
Yes,
correct?
yes.
In fact, you mentioned in an inquiry by one of the insurance companies that why are you prescribing this combination of medications? You said, I'm following what Dr. Thackeray did.
Yes, she was taking both of those things for her stomach.
Norco.
And because I did not, it ordinarily you do not combine those two things.
That's correct.
Yes, and that was why I questioned it, but it was her gastroenterologist that put her on the
All right, well, turn to the
And she said that he told her that she was supposed to take them alternately, not together.
Who told her that? Dr. Thackeray?
Yeah.
Did Dr. Thackeray ever at one point say, I don't want to treat her?
Yes, I think he did. At one time, we had to refer someplace else.
Turn to the entry on January 3, 2018. I have that tab as well.
Well, Dr. Thackeray said she did not have Crohn's disease, but we had documentation that she had colonoscopy, and she did have Crohn's disease.
Turn to that's where I'm going, doctor.
Yes.
Turn to the January 3, 2018. You agree, it reads, patient presents today with a complaint above, and that's Crohn's disease and chronic pain, which is Crohn's disease and chronic pain. Dr. Thackeray said she does not have Crohn's disease. She has actually been diagnosed with this in Jackson. He will not see her anymore.
Yeah.
Did you refer back to Jackson?
I think she went on now.
Did you obtain the records?
Yes, we had some records from her.
Show me the records post January 3, 2018.
I don't know. They're not, where are they?
Well, doctor, you have your records, so I'm asking you to.
Well, I have a lot of records here. Yes, there is some. Saw a picture of a colon somewhere. There we are. GI Associates and Endoscopy Center.
What
Is that
year?
what you're looking at?
What year?
2015.
I'm asking for post January 2018, when Dr. Thackeray said she did not have Crohn's disease.
He said that, but we have these records that say she did.
Back in 2015, doctor. I'm asking
Yes, I know, but if you have Crohn's disease in 2015, you have it in 2018 also, it doesn't go away.
I'm not trying to be argumentative, but you would agree with me that if a doctor, the most recent evaluation states that the patient is not suffering from something, and you continue to prescribe the same medication, you better find the basis that is a subsequent follow-up by that other gastroenterologist. What I'm trying to point out to you, doctor, subsequent to Dr. Thackeray saying she did not have Crohn's disease, that did not change her prescribing pattern.
Well, yes, but if you documented it in 2015, I don't know why he said that. I don't know, do you have his in here somewhere?
That's what I'm asking. Post January 2018, if you picked up the phone and called him, did you get the records and see why he rendered that decision? Or did you refer to
I
somebody? I
did
did not
speak to
see that.
him about it. And he said she didn't have Prozadine, but I already had documentation that she did.
Would you agree with that? He was in the most recent evaluation for Crohn's?
Probably.
All right. Doctor, do you agree that the concomitant use of benzodiazepines, opioids, and buprenorphine is a dangerous combination?
Yes, I do, and I was not aware at the beginning that she was taking these things. Because, and she was also taking Adderall from somebody else.
Sure.
And I told her that she has to get off of this stuff. And then we worked on getting her off of the Xanax, but it didn't do very well.
You
But
ultimately,
I mean, she got off Adderall, I think. But as far as the Xanax, she was getting that from Dr. Jenkins, the psychiatrist. But then that came out that you can't be on Xanax and opiates at the same time. So I weaned her from Xanax, supposedly. But it turns out she really didn't, because she was still taking it off the street or something. Because it was in her urine.
doctor,
Xanax.
that's right. Also, oxytocin was in her urine on multiple occasions. Would you not agree?
I don't know.
Okay. Let me ask you this.
We did have drug screens on her, right?
Fix and go over that very briefly.
Yeah.
Okay. You agree that a fair review of this record indicates multiple instances of drug-seeking behavior or red flags that this patient is abusing drugs?
That's why we were trying to wean her from this.
Would you agree with me that conduct of the patient, one of the first
Yes,
things you
I
need?
believe that this patient is a borderline personality. I believe that after everything that happened.
What I'm trying to point out to you, Doctor, let me ask a question, please. That conduct of the patient can be a clear indicator of drug abuse. Is that correct? Drug abuse or addiction behavior.
Yes, we were trying to wean her from her medicine. And we were also attempting to wean her from the Norco and just leave her underneath the Norco. But the patient did not cooperate with that, and that's when I dismissed her.
Let's talk about a few things that came to your attention today. First, conduct of the patient. I'm going to read you these entries and the date. If you want to pull to them, confirm, pull each entry, that's fine. This is conduct of the patient being indicative of drug abuse. Put in the record of July 17, 2018. She took her husband's methadone. Do you agree that's a red flag?
Yeah.
September 16, 2018, you put in the record, drug storage container was stolen, prompting her to obtain narcotics off the streets. That's an issue. Did you tell her to file a police report? Do you have a copy of it?
No, she didn't do it.
May 13, 2019, Dr. Barker, you had to instruct the patient not to peel the label off of her drug test that she takes.
Yeah.
Red flag, would you not agree?
Yes. Did I not fire her shortly thereafter?
Would you not agree that evidence of drug abuse, drug addiction behavior could also come from third parties?
From what?
Third parties.
Third party?
Let me give you an example. Notifications from CVS, like at insurance company. Let me read a couple to you and see what your response is. November 23, 2016, CVS sent you a caution letter stating the patient having, quote, an unusual use of controlled substances and other targeted medications having a high abuse potential. The letter is also attached a list of prescription claims showing the patient was getting controlled drugs from other practitioners. Do you recall that?
Yes, and that's when we found out about the Xanax and the Adderall.
back in 2016, understand. You did not terminate this patient in 2019.
Okay, well, in 2000, I mean, I don't recall that.
Let's try this. October 27, 2017, about a year later, CVS sent you another inquiry requesting the quote clinical rationale for concurrent prescribing of buprenorphine and hydrocodone, APAP.
Yes, that was what we, okay. She came on multiple things. There were 4 different controlled substances that she was taking. She was taking morphine, Norco, Adderall, Xanax, all prescribed. But 2 of them are not prescribed by me. When I found that out, we stopped the Adderall, and I think she actually stopped the Adderall. Then we started working on the Xanax, because that's when it came out that we were supposed to get them off Xanax if they were also on opiates. And I had stopped prescribing it for her, but she relapsed several times. Which Xanax is typical.
Okay. In response to the October 27 inquiry, 2017 inquiry by CVS, they asked you, what's your clinical rationale? You recall the response being, this was started by Dr. Thackeray, gastroenterologist?
Yeah.
The same Dr. Thackeray that said she didn't have Crohn's disease, right?
Yeah.
Then we have a December.
But he was treating her at the time as if she did.
Okay. Then December 3, 2017, Aetna wrote you a letter. Now, this is all out of your file now. Wrote you a letter asking you to reconsider the concomitant use of opioids and benzo. 2017. But you continued prescribing that medication, did you not?
People do not get off benzos overnight. And you're aware of that, right? I mean, we were attempting to wean. And I, ever since that came out, and even before that, none of these people were started by me on Xanax. And I do not prescribe Xanax that has not already been prescribed by somebody else. And I attempt to wean all of those people. And I have worked on it hard since that recommendation came out. And I have weaned many people, usually by switching them to Klonopin and then decreasing that. And I have gotten almost everybody off of Xanax. There are a couple that are still on a small dose of Klonopin, and that's it.
That's admirable, Dr. But let's talk about patient 3 for a moment. On January 8, 2018, CVS wrote you yet another letter regarding the potential, warning you of the potential abuse of the concomitant use of buprenorphine and gabapentin. Do you recall that? Then on January 16, 2018, Aetna sent you another caution letter regarding the chronic steroid use with no evidence of bone mineral density evaluation. Do you recall that? All right. Doctor, one of the biggest indicators, would you agree, one of the biggest indicators of possible drug-seeking behavior is no drug screen?
Well, that's one of them.
Sure. And that's the reason why the board, effective October 20, 2018, required it almost with every visit. Is that correct?
Yeah.
Multiple instances, you did very good in running urine screen. The problem, doctor, you would recognize this, that the results of this urine screen, you either ignored it or didn't understand.
We did not ignore it. We continued to work with the patient until it became obvious that the patient was not going to continue to work with us.
go back there. I'm not gonna read all of them. You have, I've got here listed 8 of about, must have been about 20 urine screens. November 11, 2017. Urine drug screen was positive for opioids, benzodiazepines, and oxycodone. You were not prescribing oxycodone to this patient. The patient's excuse, she took Percocet she had. Dr. Barker, notwithstanding cutting her off, he prescribed the same medications, Norco, buprenorphine, and Xanax. You dispute that?
I don't think so.
February 16, 2018, a positive urine drug screen for opioid, benzo, and again, oxycodone, and this time with buprenorphine. Patient's excuse, she says she does not know how the other things got to her urine, such as the oxycodone. Doctor, you didn't cut her off. You continue to prescribe the same medication. You dispute that. Just a few more. Positive urine screen for opioids, benzos, and again, oxycodone. A negative for buprenorphine. So we have another urine drug screen that's positive for a drug that you didn't prescribe and negative for a drug that you did prescribe. Do you not agree that that patient should have been terminated before you did so in 2019?
I mean, possibly yes, but we were trying to work with this patient to get her off of all the stuff that she was using.
August 17, 2018, almost a year before you finally cut her off. Positive urine drug screen for benzodiazepine, buprenorphine, negative for the opioids. So now she's not taking the Norco. Yet there was no confrontation. Her statement to you says she took some of her husband's methadone. Now, you did reduce the exam for a period of time. Is that correct?
Yeah.
Terminated the patient on June 13, 2019, but only after a May 13, 2019 last positive urine screen, which was negative for Norco. If you're prescribing Norco to a patient and it's positive and a negative, let me finish, and it's a negative urine screen, you would agree with me there's a possibility of diversion.
There's a possibility, and which we were trying at that point to wean the Norco. And she was just telling me that she was working on that, and that's why it wasn't in here. Because I'm not supposed to be on buprenorphine and Norco at the same time. So we were attempting to wean the Norco off. And I took that as she was actually trying to do that.
Doctor, in your answer, you said you did not believe this patient was a malignant. You still stand by that position?
I don't think she's so much a malinger as, like I say, I believe she has a borderline personality. So that's what I believe is wrong with this person.
Would you not agree with, based upon this record and the prescribing that you provided to patient number 3, this board to conclude that how you handle the manage this patient is prescribing a controlled substance outside the course of legitimate professional practice? You still think that?
Yes, I still think that. I think we were trying to get her off of all of her medication, except for perhaps the buprenorphine. That's what I was trying to accomplish.
You understand the board may disagree with that.
You know, but that was what I was trying to accomplish.
You would agree that prescribing a controlled substance outside the course of the legitimate professional practice, potentially harmful to the patient.
I don't agree that it's not a legitimate practice.
General principle, prescribe any physician, if you prescribe controlled substances outside the course of legitimate professional practice, that's potentially harmful to the patient.
If that was the case, yes.
The board members want to ask any questions, you want to do your,
Let's,
Can we do cross first and then, oh, yeah. Will you proceed
I'm
first?
through with my question.
Okay,
Yeah, just real quick. May I remain seated, is that okay?
yes, that's fine.
Dr. Barker, you read over the answer that we prepared for this board today?
Yeah.
And it has been entered into evidence, correct?
Uh-huh.
You stand by everything we said in that answer?
I agree.
Tell me, Dr. Barker, I noticed there's been a lot of discussion about, the rules and the regulations. However, tell me, in your experience, in particular, these three patients, especially number 3, you really seem to have a drug issue. What happens when you cut a patient like that off cold turkey?
They have withdrawals.
And what options as far as facilities or anything in Greenville at that time did you have?
At that time, we had virtually none.
And I understand based on her medical condition, would she be considered a dual diagnosis patient for inpatient treatment?
It's possible, yes.
Do you know how many dual diagnosis facilities there are in the state of Mississippi?
I think there's one.
Is there any in Greenville?
No.
Is it your testimony today that you believe you were trying to do the best by this patient by weaning her?
Yes.
That's all the questions I have.
The follow-up question, then the board
I've got a couple back to patient number 3.
Prior to that, he has one more question.
Oh, I'm sorry.
Patients 1, 2, and 3. Did you refer any one of them to a chemical dependency treatment center at any time?
We do not have any chemical dependency treatments really available. They have a psychiatric floor, they see them for 1 or 2 days. That's not gonna get people off of what you might get them off. They have an outpatient thing at the mental health. I have referred several patients to that. They have something called Arms of Mercy, which is long-term, that they will accept people that want to work on things from a Christian perspective. Stay there for long-term treatment. And that's what we've got. And when we had the psychiatrist before, Dr. Jenkins, he did not see Medicaid patients at all. He actually increased the benzodiazepines when I sent people to him. And I thought that was inappropriate. In Greenville, we have not had good psychiatric service for a long time. We now have a new young psychiatrist that's doing a better job. I use her, but still, we don't have places to send people depending on what their insurance coverage is for adequate treatment for chemical dependency. We just don't.
The board members have any questions?
I got a few. In relation to patient number 3, I also see she has postpartum cardiomyopathy, and Since you didn't really have any records from some of the other gastroenterologists, did you look into the nature of her myocardial disease, which sometimes never changes, never goes away? Her postpartum the cardiomyopathy that she had postpartum.
Yes.
Did you have any records on that to see if her myocardium would stand up to all these medications?
I didn't see her for years after that.
Well, it said it's the year
And
before.
at the time when she showed up again in my office, she was seeing a cardiologist called Dr. Watanabe, who's not there anymore.
Okay, did you have any records from that physician?
No.
Okay.
I wasn't treating cardiomyopathy at that point myself.
Okay, did it not concern you to look into every aspect of this patient's care if your specialty is family practice?
She did not have cardiac complaints at that time, and I know I did not look into that.
Okay. On this patient, you said you're trying to wean the alprazolam. What is the process of weaning? Can you describe to me what you did to actually wean this patient from this drug?
I decreased her prescriptions over time.
Okay, how do you do that?
Well, this is how I usually do it exactly with her. Okay, most people I speak.
How'd you do her? I don't care about most people.
Her, I just decreased her prescription.
Okay, tell me about that.
I think I had started with cutting her like 15 to start out with.
Okay, well, go to you have her medical record in front of
Yes.
you. Tell me, based on what did you prescribe at what intervals? Just go through prescriptions for me. And tell me what numbers you had and from one time to the next over this 2-year period that we're talking about. Actually, 4-year period, right?
He summarizes that fairly well if you want to look at that.
Yes, I'd like to look at that again.
Which patient? Number 3?
Number 3, since that's the one we're trying to
She was
wean.
initially on 1 milligram. Three times a day to Dr. Jenkins.
If you will,
She was getting it from Dr. Jenkins for a long time.
okay, I don't have that in front of me. If you will, just go down to prescriptions and give me a date and the number and an interval. Please, ma'am.
Okay. Dr. Jenkins was prescribing until 1/25/17.
Well, let's just start with you. When you picked up this patient.
I gave her 60. Then she said she wanted to go more slowly.
Okay, no, ma'am, just give me the date when you start prescribing, the dose per pill and the interval.
61 milligram. February 20th, she got 75. Oh, wait a minute. That was the Northeast. February 2nd, she got 60 in February 20th, she got 75 because she said she was not getting enough. The next month, oh, this was, I'm skipping some. She got more from Chester Jenkins there.
long did Dr. Jenkins continue prescribing the Xanax to her? When's the last entry for Dr. Jenkins?
The last one from Dr. Jenkins was 3/20/17. No, that's, yeah, it was 3/20/17.
So you and Dr. Jenkins both were giving her Xanax, and she was not getting enough. After 2017, was Dr. Jenkins giving her Xanax prescriptions anymore?
No,
Okay, so how much were you giving her after that date?
I gave her 50 in May, 45 in June, 40 in July, 35 in August, 30 in September.
Were these 1 milligram doses?
That was 1 milligram. Then in October, I switched her to half milligram tablets, and she got 60 of them, and 55 the next month. And 45 the next month.
And what month was that?
Well, I skipped one, 50, 45.
What was the date?
She got 45 on 1/17/18
Okay,
of the half milligram,
all right.
40 in February, 35 in March, 30 in April, 25 in May, 20 in June, 15 in August, 10 in September, and 5 a couple times after that, until December 2018.
Okay. And so did you prescribe any more alprazolam after that time?
No,
Okay. Did you have any drug tests after that in your office?
yes, we did.
Did they show any
Some of them were
benzos?
positive for Xanax.
It was positive
Some of them were positive for Xanax.
after you stopped prescribing?
Yes.
Okay. So what about, did you run any PMPs while you were trying to wean the patient off the Xanax? To see if somebody else was supplying that to her.
Well, we had a few of them.
Okay. And did they show other doctors prescribing Xanax or alprazolam?
There were no other prescriptions for Xanax from other doctors.
Okay. Another question about this patient mother's. You put her on Suboxone, and
I didn't put her on Suboxone. She was on buprenorphine, which is one component of Suboxone,
okay,
before I even saw her.
okay. Well, she's on buprenorphine. Why are you giving other narcotics?
Because
It's an
that's how-
agonist
that's how
antagonist.
she came to me.
Okay.
And I'm like, you're really not supposed to be doing this. But at the time, I felt like it was more important to get her off of Adderall and Xanax. And then I was gonna work on getting her off the Norco also. And we had started that process, but she refused to comply.
Okay. But you're still writing prescriptions.
That at that point was when I let her go. Because,
Okay, but you had her in your office for how many years? 2 or 3?
see, I cut her down on hydrocodone to 30 instead. She at one point had been on 90. I mean, we were working on getting rid of the hydrocodone also. But since she was not cooperating with the program, I just discontinued.
When,
And at the very end, she went to another nurse practitioner.
okay,
And that's when I fired her.
okay. At any point with this woman, did you have a contract?
Uh-huh.
Is it in her chart?
That one is it not?
There is one in the chart for patient number 3.
Okay. What all do you see in your practice? You do family practice?
Yeah. Uh-huh.
Okay.
I take care of everything that people
Okay.
bring to me.
Well, if you got somebody with congestive heart failure, are your charts just as sketchy as these? Do you
What
have,
do I always
if you have
refer
somebody
people
with congestive heart failure,
failure?
do you have the letters or the records from cardiologists and other people involved with your other patients? You have a lot of information lacking in these 3 charts. I'm wondering about the remainder of your charts in your practice.
What about, I mean, the cardiology is, a lot of it's in the hospital.
I mean, do you obtain records on other patients with other conditions for your charts?
I obtain records of their echoes and things.
Okay.
Or I order new echoes.
Okay. Dr. Owens had a question.
Yeah, just a couple. And I guess it kind of has a little to do with some of the order of questioning that you had before. So how many of your patients that you see in your practice kind of have issues related to problems with substance use or substance abuse? Like how much of your practice consists of caring for patients who have what you've identified as problems with substance use?
Chronic pain?
Just no, I didn't say that. Substance use. So problems with substance use.
How many of them have what?
How many of the patients that you see in your practice have issues related to substance use?
I don't know, maybe half of them. It's a Greenville problem.
Some people would say it's a problem, not just in Greenville, but everywhere.
I know that.
Yeah. So, and you mentioned also there are, of the patient charts that have been presented to us today, there are patients who were who had Medicaid coverage. Are you aware that Medicaid provides transportation? So if you were to refer a patient somewhere and transportation was a barrier, that they could actually utilize Medicaid transportation in order to receive services that may be outside of their local area, even within their local area sometimes. Okay.
They come to my office with it.
So I just was wondering if you were aware of that or if you discussed that with your patients, because there are some of these patients today who are actually being seen outside of their local area by other specialists.
Yeah.
And since this is something that you've seen quite a bit and you have formulated plans for weaning or addressing issues as they pertain to substance use, do you have any formal training, or have you done CME work or any additional coursework that would give you more tools to be able to do that outside of, I know you are buprenorphine waivered, but to address some of these other issues, have you done any outside coursework or any educational activities that would help to kind of sharpen your skill set in this regard?
Not specifically for benzos, no. But what I have tried to do and what I have learned to do over the years is it's easier to wean Klonopin than it is to wean Xanax. So most of them I have tried to switch to Klonopin before I weaned it.
So there's one other question that I have, and I think your situation is not uncommon across Mississippi by us being predominantly a rural state. Everybody doesn't have the luxury of practicing in a large metropolitan area. But I do think that what exactly do you perceive your role as being as a family medicine physician in an underserved area? And I ask that question because several times throughout your testimony, you've kind of talked about what people bring to you. And when you are in an underserved area, you can sometimes get overwhelmed with what's coming through the door. And I just wanted to know what your thoughts are about what your real responsibility is. Like, so there's one thing to take care of the patient, but like, how exactly do you do that? What's your role? Because they're seeing you, they're seeing 3 or 4 other people. And so where's the responsibility, or who has the responsibility to pull all of those pieces together and to be able to see that patient, not just for the problem that walks in the door, but how all of those problems kind of interact with the other, interact with one another?
Yes, that's me mostly, you know?
Well, I wasn't asking that question of you so that you could give me the answer that you think I want to hear. I'm just asking what your real feeling is of that.
Yes, I mean, I feel like patients don't benefit from just having one doctor look at their heart and one doctor look at, I mean, because people are more complex than that, and the heart doctor might not know what the GI doctor is doing and all that other thing, you know? So that's why I feel like it's good for a person to have a primary care physician.
And you do believe that that is the role of the primary care doctor?
Yeah.
That's all I got.
Mark, thank you for being with us. I'm Dan Eddy from Vicksburg. I do internal medicine and addiction medicine. And definitely want to be respectful of your long service and much underserved area of the state. Appreciate you being with us. I just have a few questions to try to clarify my thinking a bit. You have a colonoscopy from 2015 from GI Associates in Jackson. What was the diagnosis? Active. Okay. And then you have a colonoscopy from Dr. Thackeray, but he said she doesn't have it. I mean, did Dr. Thackeray provide evidence why he gave you that opinion? Is there a colonoscopy that's now negative, showing that it's, you know, that it's a remission or?
She,
It's okay to say that.
I mean, I really don't know
Okay. Okay.
if I have the most recent one from my charter.
And as an internist, I would agree with you that the extra intestinal manifestations, you know, can be painful, the polyarthritis that goes with inflammatory bowel disease. And you can still have that despite the gut being infected. So that's true. But, you know, if it's in remission, then why she still having abdominal pain is the question.
Well, I know, that's why she was referred for colonoscopy. Yeah, I mean.
But you're telling us, and we're hearing you, that a GI doctor said she didn't have it. And it's confusing when you have a 2015 diagnosis, but it could be in remission. I don't know if that's what Dr. Thackeray was conveying, but to know that, we have to have biopsy of the intestinal tract or something to show it's remission. Do you know anything about that?
I really don't know why he said that, because all the information I had said she was not really in remission. I mean, I don't know. I can't say.
And there is nothing wrong with you disputing another doctor's diagnosis, but you need to document why you're thinking that. If you're going to continue with your course of therapy, which your course of therapy was pain management using opioids for someone with a chronic non-malignant illness. And so our burden to document goes up in terms of why we're using opioids in that setting. And what I'm not hearing is that you've got that documentation in place that I understand you disagree with Dr. Thackeray, but we don't have the evidence why that is and why you're going to continue on with your treatment course despite a specialist.
Well, I think that she may have gone down again to Jackson.
Do you have reports from there?
I don't know, but I think that's the last thing I heard, that she had gone back to the one in Jackson, because she wasn't happy with Dr. Cochran.
The next question, you queried the DMP, it was patient one, and you queried the DMP after you.
No, patient one I didn't.
Or was it two after you terminated?
Two, yeah.
When you queried the DMP, did you just query for the time that you treated the patient, or did you query the whole thing?
I can only, you know, when I get the PMP, there's 3 options.
Which you can designate the time period, right? Because you're not supposed to.
Well, from 1 to 3, but beyond that, I don't know if I have.
But the reason is, it's illegal for us to query the DMP when we're not actively treating the patient. They're not, because we're invading their privacy. So, I mean, that's a problem. Okay. And how do you, we're looking at 2 terminations. You know, we use the term firing, but how do you formally terminate a doctor-patient relationship? What does that letter say?
And you're welcome to.
Is that in the record, the letter?
Dr. Barker, will you speak up, please? We can't hear you.
I'm sorry.
It wasn't in their initial record because this on patient 3 happened.
And you know you have to provide emergency medical care for at least 30 days. You have to notify the patient of that. So I'm asking if that was a formal, appropriate termination of care, or if you just told the patient I'll never come back.
I mean, we do send a letter. But we all, I mean, when we, after, she was told in the office.
I'll tell you.
But we sent, I'm pretty sure, a letter.
Because you're exactly right when you said when you just stop, they're going to go in withdrawal. And if the patient has active addiction, they're going to acquire substance, whether it's from you or somebody else. So it's, we need the same thoughtful termination of care. You have the right to terminate. absolutely, but making sure you have the appropriate, thoughtful termination of care, even in patients like this. All right.
I'm sorry, I can't comment, I'm not testifying, but if you look at the record, there's not a termination letter for patient number 2, but there is one for patient number 3.
Okay. All right, and then prescribing methadone for patient withdrawal.
That was,
Not in hindsight, but in understanding
yes,
appropriate medical,
yes, I know that that's not
why did you do it?
because I was, not thinking that day.
You know you violated federal law when you prescribe methadone
Yeah, I,
for anything related to drug addiction or withdrawal.
yeah,
That's a big deal.
well, that's, yeah, and I shouldn't have done that.
And then the last question, with the two that tie together, could you tell me specifically, you say Dr. Zachary prescribed the buprenorphine?
That's what,
That would be the first time I have ever seen a gastroenterologist prescribe buprenorphine. Who, when you assumed care and took over buprenorphine care, who was prescribing before you? This is something that would be expected for you to know before you would assume care and prescribing. Who was it?
I thought it was,
It would be on the DMV.
okay.
Which patient number, yes?
The 3. That's not Dr. Zachary.
No, it wasn't. But I mean, evidently it was what you recommended.
Dr.
Or
Beecham.
make it that way. But
Did you get a care plan from Dr. Beecham about continuing buprenorphine? Did she really come from Dr. Beecham on Norco, hydrocodone and buprenorphine? I've never seen Dr. Beecham do that.
Dr. Beecham gave her buprenorphine and hydrocodone, and Dr. Jenkins gave her Xanax.
It was the hydrocodone and buprenorphine long-term or a one-time thing? The combination.
It was long. I
Okay.
see, I can see on this list, it was long.
Okay. You said you were going to wean her off the hydrocodone at the proper time. What dose of buprenorphine was she on?
She was initially on 90.
Okay, 8 milligrams.
Oh,
She was taking them.
no, buprenorphine is 8 milligrams, the hydrocodone I was on.
I understand, but what dose of buprenorphine were you prescribed?
She was on 8
How many times a day?
3 times a day.
So what do you think that, now, we would expect you to understand how medications work if you're going to prescribe them.
Yes,
What is going on? Do you understand what's happening when you prescribe buprenorphine and hydrocodone at the same time?
yes, I do.
What is it?
Because the buprenorphine contradicts the hydrocodone. Because it's a partial antagonist.
You understand the principle of blockade with buprenorphine?
Yeah.
So you don't have to wean off hydrocodone, you can just stop it, there's no withdrawal. Did you understand that? You just stop hydrocodone. If you have 24 milligrams of buprenorphine on board, hydrocodone's not doing anything. So most likely, I mean, that's a high likelihood of conversion right there of one of those substances, which is why we don't like the DEA doesn't like more than 16 milligrams of buprenorphine a day, because above that, that do very much more, and people tend to sell the extra doses. So, man, I'm having trouble. I appreciate your winning with Xanax. I'm not critical of what you did. I agree switching to Clonidine is smarter. I wish you would have done it on that one, but you did do a long, thoughtful wean with the Xanax. You stopped the Adderall, which was fine. But why did you stop the hydrocodone? It wouldn't do her any good. And if she refused to stop it, that would have took care of it.
Yeah, I don't know. I mean, I was just feeling like you can't stop everything at once. That's how I was thinking. Yeah.
Thank you.
Any other questions, Dr. Miles?
Dr. Parker, I understand you practice in a complicated area. I grew up in the Delta, suburb of Brazil. I understand the clientele, I understand the problems there. Tell me one thing, though, you're not an addictionologist, I'm not either, but we both get caught in this situation once in a while where somebody's owned something, maybe more than one thing, and we know we need to get them off, and there's nowhere to send them. So if you're gonna try to do this, if you're gonna attack this situation, wouldn't you think a good thing to do is write a treatment plan about patient A, I'm gonna see her now and hear her problems, and here's how I'm gonna approach this. So you kind of know where you're going with this, especially if somebody looks at the chart like DEA, us, or somebody, we can tell that you're really working on weaning. Do you have these in your office?
Do I have something that I can put in there? I just have my notes, you know, I mean, I suppose I could make a note and put it in.
Like a treatment plan?
Yeah, but I don't have a treatment plan template.
Well, here in Mississippi, it's really against the law for you to wean somebody off opioids over a long period of time. You can keep them on it until you can get them somewhere. But if you're going to do it over a long period of time, you got to really have a good explanation of where you're going with this. And I didn't see in here where you had such treatment plans, and that would have been good. Also, if you have a treatment plan like this, and you're trying to decrease, let's say, pick one, methadone, and you're bringing that dose down, all of a sudden, the next urine test shows cocaine. What would your suggestion or treatment plan say there? I mean, what are you going to do about it?
I mean, what I tell them is, I discuss how often they're doing this. If it's a one-off, I continue what I'm doing. If it's something that's a problem, they need to probably go to treatment if you can find it.
Yeah, these patients can be problems. If we go back to patient one, she was on methadone. You stopped it, but her boyfriend evidently took drugs too. If you find an empty bottle that had methadone in it, let's say 90 of them, and somebody's lying in bed that's cyanotic around the mouth and nose and eyes, and it's somnolent, not breathing well, what would be the average layman's thought about this?
They said she apparently was alert when the ambulance picked her up, and she told them she did not take methadone.
But she was cyanotic,
Well, I
wasn't
know,
breathing
but her
well,
blood pressure was also
40 over 20.
Yeah. I mean, she was in shock, basically.
Okay. And whether or not a boyfriend took this or not, what would you say to somebody that came into your office and said, you know, I need a prescription for drug X here, and I want you to write me more than I'll need because I want to give some to my boyfriend?
Well, that was what that was about the lyric.
You believe that's legal or ethical or moral?
Well, no, it's not exactly ethical.
Not exactly.
No, but I mean, it may not be ethical, but it might be moral if they couldn't get it. That's all I'm saying, but it's not the right thing to do, and I don't do that at all. And I very seldom done it.
Okay.
with my friends.
Well, I think the main thing I was trying to get at was I don't see any evidence of treatment plan. So what you're trying to do with these drugs, which you're really not trained to do. We got addictionologists here, we got psychiatrists here. These people work on addiction problems. You're not there. I'm not there. It's hard to find these folks when you need them, I'll agree. But at some point, you need to say, I can't treat you anymore. You did that on patient 2 and 3.
Any other questions? Dr. Gersh, do you have any questions?
Yeah, hi, can you hear me? I'm over here on the screen. I'm Dr. Alan Gersh, and I was in a family practice residency when I got drafted. So I understand some of what your practice is like. But what I worry about is when people make a diagnosis A and they say, well, this is B is always the treatment. There's degrees of disease. So when you're talking about inflammatory colitis, it doesn't matter always so much whether they have it or don't have it. It's whether it's active or not. Can you hear what I'm saying?
Yes.
So I am concerned that you're saying they've got a disease that causes pain. I'm going to treat the disease, but you really want to use the least amount of pain medication you can. So you got to follow the treatment and course of the disease. And that's what I'm not sure about in terms of GI problems. You realize it's not always all or nothing. They have activity index on these things. And if you're in family practice, they have blood tests you can get to tell how active a disease is. Did you try looking at the degree of activity? Because if it was very low, then the symptoms weren't due to their inflammatory bowel disease. So that's my question is, how do you make a high resolution diagnosis? How do you know for sure their pain is coming from something? And is there a plan to reduce the underlying disease?
Did you hear that?
No, what was
Okay.
the question?
Yeah, because I had difficulty hearing.
What he said, in essence, was something like Crohn's disease has ups and downs. As we know, you're in remission, you're out of remission, whatever. And he's saying, did you look at segmentation rates and other indicators that her disease there was active to treat the actual Crohn's disease as a source of pain as opposed to just treating the pain? Were you treating the disease or were you just treating her symptoms?
She asked, were you treating the pain or just treating her symptoms?
That's right. Was she treating the disease?
Disease.
Was she treating the underlying disease or just pain symptoms?
No, her gastroenterologist was treating her.
Okay. Does anybody mind if we take about a 10-minute break? It looks like that's all the questions we have right now for Dr. Barker. Do you mind taking a 10-minute break?
I do not.
10-minute break.
Still talking, half of them still going,
Okay. Where are they?
hanging out.
Doc, come on. Come on down in here. among us.
Yeah.
Stan, we're not gonna have to order dinner tonight, are we?
No.
Absolutely not.
Take that as you know, to call Doug or Sue over here to help. He might be here.
Let's see, we're
Tell Doug that's a compliment.
Sure.
Dr. Cleveland and Dr. Kennard. Dr. Kennard, Dr. Lippincott.
Good.
It doesn't take many.
I'll be wide awake when I'm home.
Oh,
Here you will. And Dr. McClendon.
I didn't see him back there.
He must have found other. These guys are taking so long.
You know, sometimes it takes a little while to
Get
it going.
Say, he's not that old.
Blazed so much the last time. I could see sharp.
Need Dr. McClendon. Otherwise, he'd have to recuse himself from the rest of this and couldn't vote.
See, I was looking out for you.
Thank you, I appreciate that.
Yeah, give these all away.
I'll share it.
Okay. Okay. Everybody's back. Let's resume. Dr. Kennard had a comment or a question before Dr. Barker steps down.
Yes, I guess you can call it all of those, but Dr. Barker, I appreciate your being here too, and the years of service in the area that you work in as well. But I've practiced pain management and I did anesthesia because I was scared of going into primary care where I had to know a lot about a lot. I gravitated towards a lot about a little, and even anesthesia residency where if they're pink and post-op, you've done your job. It seemed cleaner. And what did I do? I ended up completing a fellowship, and now I'm in clinic and right where I thought I was, what I was trying to avoid. I do empathize with all of those things, but your attorney led with something that's concerning, and you led with something that's concerning to me. And that is the area that you work in is difficult to practice in, and there's not a lot of people willing and available to take care of them. To the contrary of that, when you're talking about addiction and you're prescribing controlled substances, it's actually those very patients that are most susceptible to have complications and fatalities from those treatments too. So fine line between compassionately helping them, but recognizing when it's going wrong. And the recognition needs to happen on the front end. So in my almost 15 years of practice, what I've found is the easiest way to simplify things from the get-go is I get a lot of records too from other pain clinics if I'm lucky, and I demand them sometimes before I accept the patient, but not always. I'm not too restrictive on screening criteria. The one that I use is, what is my feeling from what I have available in regards to this person's brain, not what's on paper. Pain is always going to be a reported, mostly subjective thing, because you can have Crohn's disease with pain or without. You can have scoliosis with pain or without. It's the patient's report of pain that separates them. There's no lab to draw to measure pain. But not what I'm treating, who I'm treating. So if someone's poor and less educated and in a lower socioeconomic class and doesn't have a lot of family support and social support, those are the people that are most susceptible for either coming to you or becoming an addict or dependent on drugs. There was not near enough of that going on, and just continuing something someone else was doing for a period of time until you sort things out, it's reasonable. But that's all I do all day is try to sort that out, and it's very difficult. I don't treat high blood pressure or diabetes or any of the other things that can complicate my day. All I do is practice pain management and some buprenorphine prescribing for those I think are suitable for outpatient treatment. But I have a very strict line I draw on those two when they're not fit for it. So thank you for indulging me, but effort and compassion do matter, but they don't substitute for judgment. And one of my biggest problems is not just the judgment around the opioids and the controlled substance prescribing, it's just generally. So when you led with most people that are on pain medications become addicted, I knew that you just simply didn't understand certain terminology that's a core basis for pain management standard of care. in addiction these days, and that is that addiction and dependence are black and white, completely separate terms and dealt with completely differently. Addiction is behavioral, and so we can get off into the weeds on that, but you just didn't have a system set up to identify who's who. And that actually made it more dangerous, not less, for those disenfranchised people that you're treating. My average age of my patients is closer to 55. I only saw the age of 2 of these. Case 2 is 35, case 3 is 33. I'm not sure about case 1, but that's very young to be, not for bipolar disorder, but for chronic pain. So my practice shows me internally that it takes time to develop degenerative conditions that cause a lot of chronic pain, happens over time. That 50% of your whole patient population was something you may or may not have been trying to do this with is really very concerning, because if these are 3 even average examples of what was going on, it's just not to the standard whatsoever now, and even then. So regardless of any decision that's made today going forward, you really got to reevaluate, you know, how you're approaching in a systematic fashion pain and addiction. Yeah, I bet you have, and I don't know the extent of that either. And I'm trying to be very respectful when I say that. Like I said, I think I have a good handle on the standard of care for what I'm doing on a daily basis, but I still have anxiety sometimes, and I still doubt, and it's still very difficult, and that's all I do. So just know that I don't think any of this is easy, and I don't have all the answers either. Absolutely not. One thing I'd also, for the record, total dosage units. I really hope that we don't put a lot of emphasis on total dosage units for patients out of context. By practicing chronic pain, I'm expected to probably have more chronic opioid patients than someone in family practice. That's reasonable. I'm also probably expected to write higher dosages because these people have been on them longer and have a higher tolerance. And so dosage units, if you compared mine to somebody that did some pain in a family practice, it would, if you're just using that, you'd try to throw them into the jail. It has to be in context of per prescription and how often those prescriptions are written. Your dosage units per prescription and per month were not exorbitant. That's not the issue. If they met all the criteria for all those drugs, it could be reasonable. We didn't know if they met it or not, and that's the part that wasn't done. And when you were trying to wean them, there was not enough of a plan in place, so they really didn't get to the end of their treatment spectrum ever, and some of them died. And whether they died of that or not, they are dying. So the opioid fatalities are going up as we speak, and for different reasons, but the prescribing is going down, the deaths are going up, and that's from illicit mix. But I wanted to say that so that if anybody else has access to this, the record of this, that the standard of care is higher. It's gotten higher every couple of years for practicing pain management, and there's not enough resources. That's one thing I can absolutely feel for you, but it's not an excuse to try to do something not to the standard of care because there's not enough resources. It's better just not to start it and not to perpetuate something that is problematic. So,
Okay.
Thank you.
Are there any other questions?
Yeah, Dr. Parker, when you were here back in 2016, were you required to get any continuing medical education in addition to the regular at that time?
I mean, I've only been down here one other occasion. I don't know, they say 2 patients, don't you think? I only remember 1. And it took a whole year to settle that. And no, they didn't. Because I came here, it was kind of under false misconceptions because she really wasn't done.
Well, that was another issue, but have you been participating in the required CMAs for the opiate prescribing for these years since then? Okay. That's all. Thank you.
Did you want me to clarify? She appeared back in 2017, and because of her appearance, how she reacted to the board's inquiry, that has some concern, referred her to the examining committee under the Mississippi Disabled Physician Law. And after that examination, the committee rendered an order, basically saying that they found no issue.
So she never had a consent order?
No, this is back in 2017. That's the referral to the examining committee, which ruled after the examination, they didn't have any issues with her from a mental health problem perspective, personality perspective. Then, following that, an investigation later, she appeared in front of the board after executing a consent order on February 18, 2020, last year. And that was a consent order which the board did not accept. Thus, the hearing before the board today.
If there are no further questions, you may step down. Mr. Ingram, you can call your next witness. You can call your next witness.
We're called Dr. Andrew Watson as an expert witness. For the record, would you please state your name, please?
John Andrew Watson, CO.
And your profession?
I'm board certified in emergency medicine.
You've been practicing since
1996.
you have about 25 years experience?
Close.
And your specialty, did you say?
Is emergency medicine.
Do you have a CV?
Yes.
I'm going to present what's been marked and introduce the board exhibit number 16. Is that your CV? What do you want to stipulate?
I'm going to stipulate.
Okay. Save some time. Yes. Dr. Watson, we stipulate as an expert in primary care. Do the board members have any questions of Dr. Watson from a credential standpoint?
Dr. Edney.
Dr. Watson, how much primary care have you practiced?
My training, I graduated from West Virginia School of Osteopathic Medicine. I completed a one-year internship at the University of Alabama, Birmingham, family medicine, because I thought my intensity of training needed to be more. I transferred to emergency medicine residency program at the University of Mississippi, completed that, completed all the requirements to be board certified in emergency medicine. My practice ended up with several other practitioners, physicians in Macomb. We took over the contract at Southwest Regional Medical Center. After practicing for 2 years, we noted that there was a great demand for primary care, urgent care, and immediate care. And therefore opened up the urgent care center and subsequent 3 primary care facilities. I transitioned out of the emergency department. My sole job is to supervise and manage partner for this group. I oversee the daily operations of all 4 of those clinics. See patients on an urgent care basis and immediate care basis, but also have a practice that takes care of primary care patients also.
Thank you.
So let the record reflect Dr. Watson has been admitted as an expert in the area of primary care. What records did you review today for the purpose of your testimony?
My original review for today, the original review was several more charts, but patients 1, 2, and 3.
And the prescriptions?
The medical records, the prescription monitoring, printouts, the prescriptions, everything entered as evidence.
introduced as to each of the three patients is also an opinion rendered by Dr. Raul Cora, who is a psychiatrist, I think, with the New South Neurospine. He rendered an expert opinion as to each of these three patients. Have you also reviewed those?
Yes.
For what purpose did you conduct this review?
The board requested review this for the purpose of saying that there was appropriate practice habits.
Do you agree with me that to make a determination as to whether the prescribing of Dr. Barker as to patients 1, 2, and 3 constituted prescribing outside the course of the professional practice?
Yes.
Unprofessional conduct like the harm to the public? Whether or not the appropriate paid contract was maintained for all three patients. Are you in a position now to render an expert opinion in that regard?
I am.
All right, before we get started with your three patients, we'll be brief. As a primary care physician, when a patient does present to you for chronic pain, what is the appropriate step that you take?
It's the duty of the provider to pursue burden improvement that patient requires the use of any scheduled medication, regardless if it's for chronic pain or some other condition that requires the use of medication. New patients, simply because of the way our practices are established, we do have some referral resources. We do serve a 9-county region and 2 Louisiana parishes, and we do have some local and we have regional resources. So if I have a brand new patient that shows up just wanting pain management, I'm usually going to refer them to a pain management. The majority of my patients are established, and for whatever condition that they have or may develop, they may have my interaction with them, but also I'm going to make an appropriate referral to assist in my assessment plan and everything that encompasses treating them for their chronic pain.
That includes obtaining necessary information?
Yes. If I have a new patient that shows up, I really scrutinize why they're trying to initiate that. If they're established, regardless, all patients that we take care of, I'm obtaining a detailed history. I'm reviewing their past and current medical history as it pertains to this complaint and all the other complaints. I also obtain a detailed psychiatric history, particularly if there are mood disorders, anxiety, or depression, because of the high likelihood of substance abuse associated with those psychiatric conditions. I obtain a social history, particularly regarding alcohol use, drug use, past addictions, or problems with controlled substances or alcohol. Then do a complete physical examination with an in-depth exam on the areas that may be affected that are of concern. I review any prior treatments that they have, and I question the reason why do you think you need pain management or some sort of controlled substance? And if I really believe that the patient is legitimate, and if they're a transferring patient for whatever reason, and I review that transferring physician's notes and treatment plan, then I will pursue their evaluation further. If I don't have the gestalt that their complaint is what I perceive, then I'm going to decline and I'm going to make a referral so that they can seek a more appropriate care. I review their prior compliance and adherence to their treatment plan. I want to get them, make the patient obtain a copy of their actual radiographic studies and interpretation of those studies if there was some sort of treatment that was done before. I'm then going to assimilate all that information and I'm going to sit down with the patient and I'm going to tell them, yes, I can help you. We're going to come up with this plan. And then once we do that, if I am going to take that responsibility of prescribing some potentially harmful medication on a long-term basis, I'm going to involve a certified pain management specialist to examine the patient, review my plan that I've sent them, and see if they can concur, because I'm going to have them on a periodic basis help me continue to evaluate that patient, make sure that there's nothing else that needs to be done.
Let's take patient number one. Let me back up. If a patient comes to you and says that they want methadone, they want Norco, they want whatever controlled substance, if there's a personal preference on that patient, how do you respond?
I'm usually fairly direct to that request. I do not just write a prescription just because somebody asked for that. Nor do I continue another physician's treatment plan just because it was being done in the
In other words, just because the patient comes to you and says, Dr. So-and-so down the street or Dr. So-and-so somewhere else, whether it's Mississippi, Louisiana, if it's prescribing, how much weight do you give them?
I start over and do my own evaluation, just as I stated. I will use that evidence and incorporate that in my decision making, but I'm not going to automatically assume somebody else's role continue that prescribing. So I'm going to I scrutinize my patients before initiating any sort of controlled substance use, regardless of what type.
Let's take patient number one. You've heard, you've read that patient chart. This is the one that died of an overdose. You've read that patient chart. Yes. You've looked at the prescription, prescription monitoring printout. Summarize that patient, your observations as to whether or not Dr. Barker's management of this patient was within the standard of care.
Patient number one, Dr. Barker prescribed substantial amounts of controlled substances. Patient number one was a 33-year-old female that initially saw her on December 4th, 2014, when she complained of bipolar disorder, hip pain. Well, her hip was dislocated. She thinks that bipolar disorder because of her family. From the period of December 2014 to August of 2016, a 20-month period, she received numerous prescriptions with large quantities of methadone, 10 milligrams, Lyrica. And the last clinic visit that she had, she was 5 days before her death, in which she escalated her dose of methadone. There were also a lot of other substances or medications that were prescribed, including Prozac, promethazine, Depakote, trazodone, and lithium, which also have risk factors in themselves. The patient had an obvious history of drug abuse because there was actually documentation saying that the patient recently had used crack cocaine. There was a family social history that said there was no illicit drug use, but further down there said there was recent use of crack cocaine. And there was a denotation that said that the patient had multiple family members that had drug abuse. So on the onset, from the initial encounter, Dr. Barker was put on notice and knew that there were potential critical issues that pertain to this patient with the use of controlled substances. So in the progression of the review of the records, there were no records from any prior treating physician. There were some references made to Dr. Beauchamp about injections, but it didn't describe what the injections were, what they were for, what they would be. There was just only a reference to his name. There's no other documentation regarding outside providers. As far as the diagnosis of hip and thigh injury, there's no diagnosis of prior injury about her hip, about any information from other providers. There's no diagnostic studies, imaging studies that support the diagnosis hip, thigh injury, not otherwise specified. As far as the psychiatric component, there's no in-depth exam or referral basis on the patient's psychiatric history. There's contradictory statements regarding which hip it was. Was it the right hip? Was it the left hip? Was it from an MBA? Was it a congenital issue? There was no consistency in patient number one's chart. And then there was ultimately no diagnostic studies to support, why she was having hip pain. There was no referrals to support why she was having hip pain or having that evaluated. So it really appears in this chart and the other charts that Dr. Barker purely just solely relied on the patients presenting with a complaint saying, this is what I have, this is what I need. There's no confirmation of that with the physical exam, with history, with diagnostic studies. There's no sort of pain history, where you've been as far as medication use in the past. There's no numerical documentation. There's no physical exam that documents a basic physical exam of a joint that's supposedly injured. So without having any of that done, she automatically wrote over 1,500 methadones over a period of 20 months. There's no workup or evaluation of her alleged psychiatric diagnosis, how this could potentially affect this patient's outcome. There's a history of illicit drug use, including methamphetamine. There's no addressing how this should be taken care of. There's no psychological evaluation to delineate whether this patient was even an appropriate patient for pain management. The other thing was, and I know this was in the transition period from when there wasn't requirements, but as a certified medical review officer that looks at drug screens every day, should be able to at least have a standard control custody form on a medical record if you're seeing if a person is abusing or using their drugs. There were very few, there were only 3 urine drug screens the whole 20 months that Dr. Barker treated as patient number 1. If there were, they weren't entered on the chart, so if they're not there, they weren't done as far as my opinion. The first urine drug screen was negative for amphetamines, but it didn't say anything about the prescribed medications that were supposed to be there. On June 16th, there was a drug screen that was positive for methadone and cocaine, and her boyfriend, who's there with her, apparently confirms that yes, she is using cocaine. So there's another instance of that there's evidence that this is a high-risk patient to be prescribing any controlled substance. On that same entry, the patient's boyfriend was quite upset. So it's obviously there's a diversion issue going on there. So what does that really tell you? Well, it tells you that yes, there's probably diversion, yes, there's misuse of medication, and that should be enough to intervene with the patient and then either tell them this is the way it's going to go from here on out, or we're going to stop our patient-physician relationship and terminate the relationship then. But with a person that's abusing and misusing patients, obviously this did not happen. So instead of declining, she wrote more. And then on the last visit around, it was August 15th, she increased the dosage of methadone from 10 milligrams twice a day, 3 times a day. And there's no medical justification. It's the only reason why was because the patient said that she wanted more, which is documented in the charts. 5 days later, the patient died from an overdose, whether it was her prescription or another illicit medication. This would definitely be a contributing factor to the patient's overdose. So there was also no pain management agreement that was in the chart.
You heard the testimony from Dr. Barker. She had previously prescribed this to methadone 3 per day. And so she went to 2 per day for a period of time. Do you think that justifies her increasing it to 3 per day after being advised of positive urine screen for crack cocaine and so forth?
No.
Based on your review of the medical record and testimony you observed from Dr. Barker, do you have an opinion as to whether Dr. Barker prescribed patient number 1 controlled substances or other drugs having addiction, forming or giving sustained liability outside the course of their given professional life?
Yes, I do.
What's that opinion?
Yes, that should be prescribed.
Count 2 was that you have an opinion as to whether or not you were able to find and review a pain management
contract. Is that in the file? Count three. Do you have opinions based upon your review of the medical record and observation of Dr. Barker's testimony? Do you have an opinion as to whether or not her management of the case for patient number one constitutes unprofessional conduct like which upon the patient?
Yes, I do.
Talk about patient number two.
Patient number two, this is another substantial prescription. Assuming individual, a 35-year-old female that was initially seen in June 2013 over basically a 4-year period. An enormous amount of medication is given. 2,840 doses given, so it's a controlled substance in a 4-year period.
Stop you there real quick. You heard the testimony, excuse me, the observation by Dr. Bernard that the volume of medication is not what is an issue. What is an issue?
The ease of access that Dr. Barker was prescribing medications to this patient when she would present with a monthly visit essentially for a continued acute issue, and instead of seeking corrective action, she was continuing to meet the request of the patient and prescribe some sort of controlled substance, such as a toothache that's getting taken care of for 9 visits over a 15-month period. The toothache should only be taken care of for a few days, and it's some sort of appropriate disposition made for the patient.
Are you referring to the increase found in the record which says cannot afford a dentist? She has yet to see a dentist?
Yes.
What does that say?
The patient would rather come get a prescription for the pain medicine instead of going to the dentist. There were multiple other myriad of complaints that on consecutive months that required doses of maybe twice a day, hydrocodone. And also just in the time period that she treated this patient in over 4 years, if she would have easily referred to a prescription monitoring surveillance, she could have seen that there were 15 different prescribers. There's 10 different pharmacies. There's numerous addresses that the patient is using. But ultimately, there's never really any diagnostic studies to support the etiology of the back pain. And if the PNP wasn't readily available at that time, there was a silver script information request and warning saying back in September of 2016, it said fluconazole was known to increase availability of prazolam. Even though she's not prescribing prazolam or Xanax, if that would at least trigger a reflex for me to query PNP myself, all the local pharmacy that she's using to discover if she's using something else. There were no mentions of x-rays, imaging, to address the patient's back pain. There was no neurological exam. There's no record to recommend any sort of consultation with any sort of specialist for the chronic back pain that she has. It just says that the patient has scoliosis, but there's varying degrees of scoliosis. There's never a column angle documented. There's never a physical exam documenting range of motion, flexion, extension, rotation, side bending, any basic physical exam to document the degree of restriction or impairment that's causing the severity of this patient's pain. And then, the drug seeking behavior finally at the end, when the patient presents with an opioid withdrawal, she tries to start suboxone, writes methadone, which is contrary to any practice of any sort of medicine, regardless. The patient comes back and claims she flushed it down the toilet. Then, at this point, it acknowledges, Dr. Barker acknowledges that she discovers on the PNP that the patient's, now she finds out that she's seeing multiple other providers and has been diverting or misusing her medication.
when a patient comes to you with a myriad of pain, sources of pain, in this case, I'm referring to toothache, abdominal pain, ear pain, headaches, eye, joint, pelvis, thumb, neck pain, facial pain, what does that do?
Usually the patient's malingering and attempting to find some valid excuse to obtain control substance.
While Dr. Barker's ultimate termination of this patient occurred June 19, 2017, for a deal saying day late and $1 short. What is your opinion in that regard? Should that have been done earlier? What should have been done?
The patient should have been scrutinized. First of all, a continual, essentially monthly volume of pain medication. And you're doing that month after month. That's pain management for whatever reason. So there was no standard or guidelines met in regards. There was just a continual issuance of pain medication, which is inappropriate.
Based on your review of the medical record for patient number 2 and observation of Dr. Barker's testimony, do you have an opinion as to whether or not she prescribed narcotic drugs or other drugs having addiction performing or addiction sustaining liability outside the course of legitimate professional practice?
Yes.
That it was outside.
It was outside.
Did you find a pain management contract in this file?
No.
That's count 5. Count 6. Based upon your review of the medical record, prescriptions, and a testimony of Dr. Barker, do you have an opinion as to whether or not her practice constitutes, her management of this patient, constitutes unprofessional conduct likely to harm the patient?
Yes.
Let's talk about patient number 3. Last patient.
Patient number 3 is a 33-year-old female. She initially presented with depression, chronic anxiety, postpartum cardiomyopathy. There was an inquiry for a statement saying that the patient thought she may be bipolar. There was an 8-year gap, and the patient returned with a diagnosis of Crohn and chronic abdominal pain. Immediately from there, there was controlled substances of hydrocodone and buprenorphine that have been prescribed by other prescribers that were issued without any evidence of scrutiny or investigation into the patient's diagnosis or needs and continuance of that medication. Dr. Barker treated the patient from October of 2016 to June of 2019. Over that period, Dr. Barker issued numerous medications, including Norco, buprenorphine, alprazolam, and clonazepam, which have black box warnings and are contraindicated to be prescribed in conjunction with each other, which is a danger to the public. Claims that she did not have a polyarthritis were initially, in her initial exam, she documented that there was joint involvement, and the patient was also having pain. So, and in every encounter throughout the chart, there's always a mention of inflammatory polyarthropathy, in addition to Crohn's disease and chronic pain. The polyarthropathy, if it was present, was never addressed on physical exam except in the initial exam. After that, there was always a normal physical exam regarding the musculoskeletal system. So if it was a chronic inflammatory process, it's my opinion that some sort of rheumatological referral should have been made instead of continuing to treat that. Crohn's referral, the initial evaluation. The GI associates did have biopsy proven Crohn's disease, but the endoscopies were all normal. Dr. Vicari at some point in February of 2017 did a colonoscopy and saw no evidence of active inflammation. So with his comments that she does not have Crohn's disease, I would say that she probably, if he did not see active Crohn's disease, would not see her anymore. Despite this, there was continued prescriptions for benzodiazepines, opioids, and buprenorphine, which, as I stated earlier, are contraindicated for concomitant use. There's evidence of drug abuse, drug-seeking behavior. Dr. Barker should have been aware of these in several different ways. She actually documented that the patient took her method. She took her husband's methadone in July of 2018. The patient told Dr. Barker that a drug storage container was stolen, so she obtained medications off the street. She had to direct Dr. Barker had to direct the patient one time not to peel the label off the drug test when she takes it. So those are, behaviors that needed to be addressed. And if they weren't satisfied immediately, the patient should have been terminated and their disposition made elsewhere. The other thing, there were third parties. I'm sure you've all seen them, CVS, Caremark, or Aetna, or whoever you're writing medications occasionally, but you may not necessarily agree with them if they're contraindicated or not, but they do raise concern. When drug companies start sending you letters saying that there's basically 6 or 7 different notations that there's the patient's having a high abuse potential with these controlled substances, what's the rationale of you prescribing buprenorphine and hydrocodone together? And if somebody else would do it, I'm going to do it. Causing the use of opioids and benzodiazepines, the buprenorphine and gabapentin, just a repetitive, and these are never addressed. The urine drug screens. Now, this patient did have urine drug screens. That was appropriate. She had 16, and 75% of those were abnormal. I mean, they had a substance. I'm not going to go through every one unless you want me to, but there were 3/4 of these, either there was a substance that wasn't prescribed, the urine was absence of substance that was prescribed, or there was an illicit substance or a Schedule I narcotic that was present in the urine. So this is behavior that should have been addressed, but it's continuing to allow to continue the lack of addressing that in a more aggressive and appropriate manner is a danger.
Well, she terminated this patient on June 13, 2019. You found that to be appropriate?
Yes, that's appropriate. I think the reducing of the prazolam dosages were appropriate. I would have done that in a much more rapid manner instead of a several months taper. But yes, I do agree with that effort that she did.
Is it your opinion that action should have been taken well before June 13, 2019?
Yes.
Based on your review of the medical record, prescriptions, and testimony of Dr. Barker, do you have an opinion as to whether Dr. Barker prescribed controlled substances outside the course of legitimate professional practice?
Yes, I do.
Do you have an opinion as to whether Dr. Barker conduct and management of patient number 3 constituted unprofessional conduct likely to harm the patient?
Yes, I do.
Now, you heard reference to the 3 separate opinions which have gone to the record for patients 1, 2, and 3 as rendered by Dr. Raul Bora.
Correct.
Did you have a chance to read those?
I read those, yes.
Without having to go through those, did you agree with this observation?
Yes, the same observations I made in an earlier review.
Do the board members have any questions?
Cross-examination.
We'll let you cross first and then go with your question. You don't? Perfect.
Any questions for Dr. Watson? Dr. McClendon?
Dr. Watson, this Crohn's disease questionable diagnosis, was there ever any sign on the chart of ever any actual appropriate medical therapy for Crohn's disease?
There was immune therapy, prednisone, that were fantastic, that was prescribed on a chronic basis. The one thing that was of concern was of all the medical records that were reviewed, there were only 2 abdominal exams that were documented. So if I'm treating someone with abdominal pain, or examine that patient to just make sure that there's not something else going on.
Did you see, you would think if a Crohn's disease patient was having polyarthritis that you would likely be dealing with a severe case, and that they would potentially be in the hospital on a semi-regular basis with Crohn's flares?
Well, I'm not an expert in Crohn's or gastroenterology, but typically in the presentation, if a person has extra abdominal manifestations of Crohn's, it usually affects multiple organ systems. And if one's inflamed, typically all are inflamed. And since there was no mention of other organ systems being involved, that should raise some concern on the treating physician.
Sure.
Any other questions for Dr. Watson?
I have no other questions.
Perfect. You may step down.
Thank you.
At this time, will I take any closing if there aren't any other witnesses?
I call no other witnesses. Rest the case, so to speak.
Okay. Do you have a closing argument you'd like to make, or would you like to let council proceed?
Do you have any witnesses you want to?
I do not have any witnesses. Thank you so much.
You're welcome.
Closing argument. I'll be very brief. I'm not going to go through, summarize all the facts. I think the evidence speaks for itself. It's never been my responsibility. It's never been my desire to tell the board what to do. But whatever action you take today, it's substantially supported by the evidence that's been introduced. That's basically all I have to say.
Just briefly, I'm of the same position as Mr. Ingram, not presenting to tell the board what to do or not to do. However, I would hope that, the evidence does speak for itself. Testimony is what the testimony is. She's been in this practicing for 30 years. I think she's willing and able to go the distance, whatever the board decides, including whatever they want, including what was in that consent order. So I would just ask that you please keep that in mind. Thank you.
Yes.
Who hired the doctor that spoke a few minutes ago?
The board.
Okay. And how much does that cost?
Previously practiced medicine in the state of Mississippi, and as a physician in the state of Mississippi, it's our responsibility, if the governing board of our licensure group requests that you make an opinion on the college. And that's why I'm here. I'm not being paid or compensated.
You say you have been?
I have not.
At this time, we will entertain a motion.
Okay, I need a motion to pause the regular session. Dr. Owens, a second.
Second.
Dr. McClendon, all in favor of pausing to consider executive? Yes, Dr. Gersh, is that a yes?
He's voting.
All in favor?
Aye.
Any opposed? Okay. Then we will step out from regular session and consider executive session.
Oops. I've been, darn it, it's not here today.
Is everybody here? We're back in regular session? Okay, Dr. Kennard. There's- Okay, we have everybody back, and we're back in regular session. Second session has ended. Dr. Owens is going to read the decisions from the executive session.
Regarding the hearing in the case of Jean Marie Barker, MD, the board finds the licensee guilty on all 8 counts. As such, the board's decision is to suspend the license her license indefinitely pending a comprehensive neuropsychological evaluation at a board-approved facility and a clinical competency evaluation by a board-approved entity. The licensee may reappear no sooner than 1 year from the date of the execution of the order.
Do you have any questions, Dr. Barker?
We get a copy of that.
You will receive that in writing.
We will, in that writing.
Yes. Dr. Cleveland, this board will have a list of those places where those evaluations can be made that we approve of, and we will get that information to you as well.
And does the board have any requirements for the qualifications list? What does she need to do in order to, did I understand that correctly? Suspending her license right now.
For suspending her license, no.
What obligations does she have as far as the qualifications?
She'll have to send them a letter that right now she can't take care of them. They're going to have to, and she can make her records available to whoever they go to. That's it. Thank you very much. Thank you for being here. Is there any further business? Any old business or anything new we need to talk about? We've already taken care of, I guess Francis will be back with us about, well, all that's done online with the Federation, and we've got our new date for our next meeting. Anything else? Anything we didn't cover or didn't put our amen on that were any documentation we're supposed to have done. Well, I thank all of you for being here and hope everybody has a safe travel back home. And Lord willing, we'll see y'all again in March.
Thank you.
We are adjourned.